సిస్టంలో పవర్ పాయింట్ సార్
నేను యూట్యూబ్ లోకి వెళ్ళమను.
లైవ్ స్ట్రీమ్ లేదు సార్.
100 ఉన్నారు కానీ 100 ఉన్నారు. గుడ్ థింగ్.
అదే శ్రీకాకుళం నుంచి జానకి బాబు గారు కాల్ చేశారు సార్.
It is showing that the meeting is now live streaming, sir, on YouTube.
Yes, yes. YouTube they can join.
Yeah.
This I am paying about ఏ బాబు గారు అన్నా యూట్యూబ్ లో యూట్యూబ్ లైవ్ ఉంది. Now it is on YouTube live. Everybody can join. And so EMRI Green is now existing. They are also doing the programs. Actually, our people in India are very much fascinated towards the working with the American Heart Association. When we have come up with the Indian Resuscitation guidelines, and even when we are recognized by the ILCAR, even then they are not able to chew the things or mince their meat. So this is the affair, but let us not bother about that. Our guidelines are, we have our guidelines. We are very cost effective in teaching. We are very simple, and our manuals are very simple. Now,
Mr. Lakshmanarayana.
Okay, come.
Sir, ఇది చాలా మంది యూట్యూబ్ లింక్ అడుగుతున్నారు సార్.
యూట్యూబ్ లింక్ యూట్యూబ్ లోకి వెళ్తే ఇట్ ఈస్ సీన్ ఇండియన్ రెసిస్ట్రేషన్ కౌన్సిల్ ఫెడరేషన్ పర్సనల్ మీటింగ్ రూమ్ అని యూట్యూబ్ లో చూడమని. అది ఎవరికైనా మెసేజ్ పంపగలం, బయట ఉన్న వాళ్ళకి మెసేజ్ ఎలా పంపుతాం?
అది సిఆర్టీసీ ఏపీలో పెట్టండి సార్.
అందులో పెట్టి ఇది మన వాట్సాప్ లో పెట్టేస్తే. సో I shared it on the YouTube, the same group. CRTC Andhra Pradesh lo unde, so they can follow it. So why we are conducting this is to just know how our people are teaching, how they are inclined to the guidelines. And I do not want you to talk more than what is given in the slides, and it is not necessary. And you are always, most of the times, you are teaching. The BCLS means you are teaching anybody, either doctor or paramedics or healthcare providers or the school children or anybody. So here, the important thing is, when we are teaching them, you need not teach. That's why actually I have to assess your pre-assessment. We need not teach the physiology and pathology of everything for the nurses and all those things. What you have to do, the most important thing in CPR is don't lose the time. Every 1 minute delay will decreases the chances of survival by 7 to 10%. So it's all known to you. Now I will share the screen. So we have given some nomenclatures also. We have changed some nomenclature because there was a regular inquiry from the AHA that what we are doing, as if that we are copying them or doing something else. And they have even the vice president of the finances has called me many times and asked us to join them. I told them our people cannot afford that much of money to pay you. That's why we have started our own thing. Even then, they have asked us our books. They have examined for plagiarism and so many things. Now our books are copyrighted by our own, and it was really belongs to the Indian Resuscitation Council. Now the Indian Resuscitation Council has changed to Indian Resuscitation Council Federation in September 7th of September 2001. So it was registered as a federation. The federation has got Indian Association of Pediatrics, IMA, ISA, and ISCCM, the Trained Nurses Association of India, the emergency life support providers, education providers, because there was a lot of problem with the emergency medicine people, where they have their own societies and they do not want to mix with us. And there was a lot of issues among themselves. There is one semi and this one is there. And they have even written to the ILCAR how you could give a recognition to IRCF, because we have not given them any letter that we are working with them. Then they said, no, you have not given the letter. It is all right. But emergency medicine educators is another group that actually was created by us to work with us, because we want emergency medicine people, and these people will be slowly coming. Even now, the emergency medicine physicians, professors, many of the professors, they have expressed their desire to join us and work with us, including Dr. Mrs. Aruna Ramesh. She told me, because she has not given me a letter, or Narendra Jana, and all these people are with us, and they are, and there are certain people in, I don't want to name them, they are always thinking they are very high of themselves, and they are, now BCLS, the BCLS, it is actually, it is called BLS with the American Heart Association, but we are calling it as basic cardiopulmonary life support, because we don't want any headache from those people. So this is BCLS. Who is teaching this?
Sir, Prashanti.
Prashanti, okay. Prashanti, shall I change the slide?
Yes, sir.
Prashanti is she is is a qualified emergency medicine physician and anesthesiologist from Guntur. Till yesterday, she was the president of the Indian Society of Anesthesiologists of Andhra Pradesh. Prashanti, you are talking about cardiopulmonary life support.
Thank you, sir, for your kind introduction. Good evening, everyone. Sir, I am audible?
Yes, you are audible.
Yes. Today we are going to just revise the BCLS core link and algorithm, scene safety, call for help, checking pulse and respiration. We have 4 core links in adult BCLS. To start with, BCLS, we have identified it as green color, and we have 4 core links. And what is the essentiality of core links is, these are also called essential core links, because these are the very important links that we have to do while we are doing this BCLS. So they influence the optimal outcome of CPR. And this depends on certain focused links that need to be followed during CPR. And so these are called the essential core links of BCLS. So these are the 4 essential core links. One is early recognition and activation. The other one is early high quality CPR. Third one, early defibrillation. Fourth one, early transfer.
One word here, the core links. Actually, we named this as core links. In other guidelines, it is chain of survival, they say. But because we do not want to copy this, we call it the core links, and we have our own this thing. When you observe our teaching, you will not find anything downloaded from the internet or any foreign face or anything. It is all Indian, and all are drawn and digitally and created one. Shall I go to you? You tell me whenever you want to change for next slide.
Sir. So in these 4 core links, one word is common, that is early. So as sir told earlier, early, we have to be early because every 1 minute delay in resuscitation will decrease the chances of survival by 7 to 10%. That is why every core link has got early recognition, early high quality CPR, early defibrillation, and early transfer. So while we are teaching it or while we are doing BCLS also, we have to keep in mind that this should be, every step should be early. So the first step is early recognition and activation. So we have to recognize that the patient is unresponsive or there is a cardiac arrest, and we have to activate the emergency medical systems. This is the first core link. Then we have to do early high quality CPR. Here high quality should be stressed because CPR should be done with high quality to be effective. Then only the BCLS what we did will have a proper effective outcome. Then the third link is early defibrillation. So we should get an AED or a defibrillator as early as possible because early defibrillation increases the chances of survival. And the fourth link is early transfer. After doing all these steps early, as fast as possible, we should transfer the patient or victim to the nearest medical facility, that too early. So these are the 4 core links of adult BCLS: early recognition activation, early high quality CPR, early defibrillation, and early transfer. Next slide.
Next slide.
Next slide, please. So when we come across 3 scenarios. You observe a person suddenly collapsing in front of you, or somebody is already collapsed when you have seen him or her first, or you have arrived at a scene where a layperson has already started providing CPR. These are the 3 scenarios we come across where we have to do the BCLS. Next slide, please. So this is the algorithm of BCLS. This includes all the steps we have to follow to do the BCLS. So each step should be followed as it is. There should be no jumbling or addition of our own steps because these are designed after a lot of research. So these should be followed as it is. This is the algorithm of BCLS. So there are the very first step of this BCLS algorithm is ensure safe place. Sir, next slide, please.
Next. Scene safety.
1 minute.
We are stopping sharing just to have a click here.
Sir, you have stopped. Please share, sir.
Good links.
Dr. Prasanthi, this is Dr. Rashesh Diwan here.
Sir, good evening.
Good evening. They are trying to make more convenient as in a slide format with the full screen so that only clicking it will change. Not you don't have to scroll. So they Arun is trying to modify it a little bit. So hold it for a minute probably.
Sure, sir.
Now it is full mode. Okay. Leave those.
Yes.
Okay.
Ensure safe place. This is the first step and the very important step of doing resuscitation. So we have to be safe before we start resuscitating a victim. So we have to be safe, and then we have to shift the victim to a safer place. So if you observe, this person is standing on the train and he is probably electrocuted, and we cannot jump onto the train and do resuscitation there. So we have to get that person down and then start resuscitation at a safe place. And if we see this train accident, that victim might have been strangled in that train, and we have to get that victim outside and do resuscitation. And in this fire accident, we should not get into that house and endanger ourselves. And in this traffic also, we have to get this victim to a safer place out of the road, and then we should start resuscitation. So in gyms, we commonly see when this person is doing a treadmill, if he collapses on the treadmill, we have to switch off the treadmill, get that person off the treadmill, place him on the ground, and then start resuscitation. Next slide, please. Next slide.
Next slide. Forest. Next slide is shown.
I'm not able to, it's not changed, sir.
Change. Arun. Change avutaledanడి అక్కడ.
Sir, shall I do it for you?
Yes, sir.
Okay. So you stop sharing and give me the powers of sharing. Okay.
It is given to all participants. Even she can do it.
Yeah, that's the best if she can.
Then I will share it, sir. I will do it.
Okay.
Yes, sir.
That's best. Yeah.
Yes.
But you should open the presentation in such a way that you don't have to scroll. It should change with click like PowerPoint. There is a facility that like that in PDF. Everybody must learn it.
Okay, sir. From next time I will learn it, sir.
Yeah.
So here the patient has to be shifted to a safe place. You can observe it is colored in blue, how we are shifting this patient victim to a safer place. So if you observe, they are holding the patient by both the hands and dragging the patient. Okay. So away from the site to a safer place. Then the second step, the first step is ensure safe place. Then the second step is you have to check the response. So tap the shoulder from the front. You should place yourself in front of the patient, not from the back. Tap the shoulder from the front and you should ask loudly, hello, are you all right? We can ask the patient in the local language, hello, or if the patient is all right in a local language, because we always respond to our local language first. So if you see the image, this rescuer is tapping on the shoulders. We should only tap on the shoulders. We should not
Clapping.
yes, we should not move the shoulders, or we should not shake the shoulders, because any person who has fallen and unconscious or who has fallen is considered to be having cervical spine injury unless proved otherwise. So we should only tap on the shoulders from the front. Don't shake the shoulders, because we are going to cause cervical spine injury. So while doing so, we have to check the response. What is the response we expect from that person? If that person is conscious or is semi-conscious, he should be able to do a verbal response or a purposeful movement of the limbs, or eye opening, or a breathing, or a coughing, chest rise or abdominal movements, or limb movements. These are all the signs of life. We should look for this response while we are tapping on the shoulder and asking loudly, hello, are you all right? So now we have checked for response. If the patient is responsive, we have to place the patient in recovery position and shift to the nearest medical facility. Suppose the patient is not responsive, then we should go to the third step, that is shout for help and call the 108 or local emergency number. See, we are doing two steps here. Shout for help. This is for the local help. We should get nearby help. Somebody might be nearby us. We should shout for help and get their help also. And then we should call the 108 or the local emergency number to get the AED or defibrillator or other emergency equipments. When we shout for help, someone nearby might come. We might go to the next step, and we can ask that person to call the 108 and inform the 108 people. So this is why we should do shout for help, why we should get a local person to help, because we want to do early activation of the emergency medical systems. And then when we call the local emergency number or 108, what are we supposed to do? What are we supposed to tell? See, in this diagram, she is calling for help. Then she is calling taking the phone and dialed 108. See, you all should remember that we can dial 108 from our cell phones also. So we should dial 108 and we should tell the emergency medical system people all this information. We should identify ourselves. We are so and so at so and so location, And we should tell the victim's condition, number of the victims present, age of the victims, that is an approximate age, or the sex, male or female, child or adult, complaint, conscious or unconscious, or some fracture or something, general condition. And you should also intimate them the number of rescuers present, how many rescuers we are having. And then we should assure that the person who is listening, that is the emergency medical systems person who is listening to you, has understood what you are telling, and then only you should hang when asked to do so. This is a very important and crucial step. We should tell them all the information clearly, and then we should assure that he understood everything, and then only hang when he says okay. Then this is these three steps. With these three steps, we finish the first core link, that is early recognition and activation. So these three steps are ensure safe place, check response, and shout for help and call the local emergency number. Then we have to do a early high quality CPR. So to do the early high quality CPR, we should first determine ourselves whether that patient is breathing, whether there is a respiration, or there is a pulse, or pulse is absent, or respiration is absent, or both are absent, or both are present. So what we should do is, the next step is, we should check for breathing while palpating the carotid pulse. Here we are doing two things at a time within 5 to 10 seconds. That is, we are trying to do two things in a short time, 5 to 10 seconds. We should do two things. Check breathing. With both the eyes, we should scan the chest. See this image, what this rescuer is trying to do with both his eyes, he is scanning the chest for chest movement. So he is checking the breathing, and at the same time he is checking for carotid pulse, and he is palpating for the carotid pulse. When there is a cardiac arrest, or when we are suspecting a cardiac arrest, we have to palpate only the carotid pulse to determine whether there is a pulse or not, because that is the pulse that is nearer to the heart, and that is the pulse that is last one to disappear. Okay, so within 5 to 10 seconds, we have to check for breathing simultaneously while palpating for the carotid pulse. So how to assess for pulse and breathing? See, how to feel for the carotid pulse? We have to use our two fingers, locate the thyroid prominence. See, you locate the middle of the chin, then locate the thyroid, draw it along the middle of the neck, locate the thyroid prominence and trachea, and slide into the groove between the trachea and the neck muscles. That is on the same side. If you are sitting on the right side, you have to slide into the groove between trachea and neck muscles onto the right side. If you are on the left side, you have to check on the left side. So ipsilateral carotid pulse should be checked, and you have to check on only one side. Don't check on both the carotid pulses at same time. So palpate for 5 to 10 seconds. And when now our eyes are engaged for scanning the chest, our fingers are engaged for palpating the carotid pulse. Now, how do we know the time? 5 to 10 seconds. We cannot use our lift our hand and see the time. So we have to use we should chant 1001. That accounts to 1 second. 1001, 1002, 1003, like that till 1010. So while chanting, we have to palpate for the carotid pulse and we have to scan the chest for breathing. So here it is written, simultaneously scan the chest or abdomen for breathing. Now, we have got three scenarios here. One is normal breathing, definite carotid pulse. Abnormal breathing or no breathing with a definite carotid pulse. What is abnormal breathing is, suppose he is, what do you say, gasping. He is gasping, it is called abnormal breathing or no breathing. And there is a third scenario is abnormal or no breathing without definite carotid pulse. In these three scenarios, we have to determine what to do, the next step. Suppose the patient is breathing normally and we are able to find a definite carotid pulse, then we have to place the patient in a recovery position, reassess every 2 minutes and shift to the nearest medical facility as soon as the transfer facility is available. Suppose there is no breathing with a definite carotid pulse. We have to provide one breath every 5 seconds. That is, in 1 minute, we will be giving approximately 12 breaths. And we should reassess every 2 minutes. Suppose there is no breathing and no definite carotid pulse, we should start cycles of 30 chest compressions and 2 breaths. Here, you should understand one important point. There is no breathing, no pulse, but what we did first is started 30 chest compressions first, then breaths. So we are putting circulation in front of respiration, ahead of respiration. So this we are giving more importance for circulation for the vital organs, brain. Okay, so when there is no breathing without any definite carotid pulse, first start 30 chest compressions, then give 2 rescue breaths. So these are the 3 scenarios we will come across when we check for breathing and carotid pulse. Then we have checked for breathing, carotid pulse. Yes. So how many cycles of 30 compressions and 2 breaths? 30 compressions and 2 breaths constitute 1 cycle. Like this, we have to do 5 cycles in 2 minutes. 5 cycles of 30 chest compressions and 2 breaths. Then we should check for, after the 5 cycles are over, we should check for carotid pulse, and that too within 5 to 10 seconds, and breaths. Simultaneously, we have to check. Okay. Then suppose pulse is present. What we should do? Pulse is present but no breathing. Then we should provide breaths only. Pulse is absent. We should do the chest compressions again. Okay. So like that, we have to continue the cycles of chest compressions and breaths till an AED or defibrillator is available. So now victim started breathing. So here the three scenarios. Victim started breathing after we did chest compressions. Pulse is present and breathing also present. Victim started breathing. Then we should place the victim in recovery position. So from first slide itself, we are talking about place the patient in recovery position. Patient is responsive, place the patient in recovery position. Patient has breathing and carotid pulse, place the patient in recovery position. What is this recovery position? Why we should keep this patient in or victim in recovery position? What is this importance? So the importance of placing this patient in recovery position is we want to prevent aspiration. This patient has just recovered from a cardiac arrest and he might vomit. When he vomits, if he is in supine position, there is every chance of aspirating. That is, the vomiters or secretions going into the lungs, thereby leading to infection again. So we want to prevent this. So we want to place this position in a lateral position, that is the recovery position. So these are the 4 steps we have to do, we have to follow to keep the victim in recovery position. First, this patient is in supine position. First, you have to keep this left hand in Tata bye-bye position, the elbow at right angles. Okay. Then we have to turn this patient so that we place his right hand under his left ear. Okay. We place his right hand under his left ear. Then you keep the lower leg, that is on the lower side leg, straight, and the upper leg in a flexed position. Okay. So this is the recovery position. So if the victim starts to breathe normally, we have to place the victim in recovery position and we have to then shift the patient to the nearest medical facility available. So to recap, if we see this algorithm once again, I shall go first. Ensure safe place, then check response, tap on shoulders from front, ask loudly, hello, are you all right, in your local language. If responsive, observe victim recovery position, shift to nearest medical facility. Non-responsive, shout for help, call 108 or local emergency to get AED or defibrillator and emergency equipments. While calling, you give all the information, assure that he got all the information understood and hang up only when asked to do so. And next step is check breathing while palpating the carotid pulse, and you will get these one of these 3 scenarios. If he is normally breathing with a definite carotid pulse, recovery position, reassess every 2 minutes, shift to nearest medical facility. Abnormal or no breathing with definite carotid pulse, provide 1 breath every 5 seconds, reassess every 2 minutes. Normal, no breathing or no carotid pulse, start cycles of 30 chest compressions and 2 breaths, 5 cycles, 30 chest compressions and 2 breaths, 2 minutes. And then when the check carotid pulse every 2 minutes, when there is a pulse, you have to give breaths again. When there is no pulse, you have to again start cycles of chest compressions and 2 breaths. Once the AED, you have to continue this cycles of chest compressions and breaths till the AED arrives and or defibrillator arrives. And once the victim starts to breathe normally, you have to place the victim in recovery position. Thank you.
Okay, one question to you, Prashanti.
Yes, sir.
Sir, Rashid Devan, sir, is there. Suppose the AED has come much earlier, what do you do?
Sir, the earlier the defibrillation, the more chances of survival of the patient. So we connect the AED and without interrupting chest compressions, we will connect the pads, sir. And once the AED is ready and it is analyzing, then we can get back.
Yes, that's what I want actually. Don't wait for the 5 cycles of chest compression and wait for the AED. Of course, as soon as the AED comes, you can immediately give a shot.
Yes, sir.
Next.
Thank you, sir.
Next, who is coming? Sir Rashid Devan, sir. Will you have a comment?
Yes, sir. This is the most important lecture to create the background of what is the value of immediate resuscitation. So when we talk to particularly paramedics, when we talk, and we are going to have a very big program, we should emphasize that early word, and she did it very well, that every link has a first word early. Now, what we say at this stage is, we talk a little longer, but we should be able to talk very briefly, but convey the right thing to the students. What we tell is the early means, if somebody collapses, it could be within the hospital premise or outside. If he doesn't have a cardiac arrest, we have all the time. But if it doesn't, if he has a cardiac arrest, his duty to establish that there is a cardiac arrest. And most important step is to establish the compression, so that you establish the circulation. For that, we have to undergo the algorithm. That's why we call it a rule of 10 seconds. So first 10 seconds, you check the scene safety. Second 10 seconds, you check the responsiveness. Third 10 seconds, you ask someone to call for the help, or you do it if possible with your speakerphone and mobile phone. And next 10 seconds, fourth 10 seconds is you check the pulse and respiration. So now that 10 seconds rule, we need to emphasize. That does not mean that exactly in 10 seconds they do it, but that emphasizes that it has to be done as quick as possible. So we have to exaggerate what we tell, the value of seconds. We don't have minutes to ascertain cardiac arrest and establish the circulation, because as quick as possible circulation is, perfusion is established, their survival chance increases, and their survival without neurological damage increases. These two things we need to emphasize a lot. That's why this first lecture is very important, where you establish in the mindset that quickness is very important to establish cardiac arrest and establish the perfusion. Otherwise, everything was perfect. We can have more comments when you go for the next. Now at this stage, we tell that we had the overview of guidelines. Now every fraction of the overview we are going to talk in details. So you start with the lecture on compression. So who is coming next?
Now,
Sir,
sir,
I want to
Srinivas Rao.
Yes, Srinivas sir.
Srinivas Rao is now the
Sir,
president of the AP ISA. No, not the president elect.
Yes, sir. Sir, shall I want to share some few things about the previous topic, sir?
I'm asking him to coordinate all the 40 CRTCs and see how they are going, how we are doing, and all those things. So he will be a state coordinator for the IRCF, and he will be working in unison with every CRTC. Yes, Srinivas.
Sir, shall I want to share some few words regarding previous lecture?
Yes.
So, as it is a TOT, all are the faculty members. One thing is very important: the palpating the carotid pulse. So there, all your faculty, you made all the participant to palpate their own carotids, and you tell them to palpate the other person's carotid also, because palpating the carotid is a very important step that will take the deviate to the scenario to other side. If you palpate that carotid is there, breathing is not there, then you will go to some other way. So that's why you made all the participants who are, when you are giving the training, you made all the participants to palpate their own carotids and their colleagues' carotid also, to take some time and teach them how to palpate the carotid, because it is a very important step. Thank you, sir. And the next topic, sir.
Absolutely right. What Sorry,
Just
only
Chest compression, sir.
a lot of
Let's chest compression, please.
noise coming.
Padmaja madam, please mute, madam.
Yeah,
Padmaja madam, please. Thank you.
she has done. So carotid pulse is the only sign which will tell concretely that there is a cardiac arrest. There is a stoppage of the circulation. So that you must emphasize. And normally what I do is I give a homework. Prasanthi knows I recently, and Dr. Padmaja also knows, that we ask them to palpate normal 150 carotid pulse of different gender and different age and different types of necks, short neck, no neck, long neck, slim neck, so that, and that has to be done in 10 seconds. So this is normally I tell them to practice, and for the anesthesiologist, I tell that as a part of PSC, you must do.
Yes, sir.
Yes.
Share your skin because
You know, confident to tell no carotid pulse in 10 seconds.
Yes, sir.
Okay,
Yes.
go to next lecture.
Yes.
Sir,
Sir,
chest compression, sir.
Yes, sir.
Chakra, sir.
Chapman,
Sir, Lakshminarayan, can I talk?
please.
Yes, sir. I just want to add one thing.
Ah.
During recovery, when you turn a patient from the supine position to the recovery position, you have to hold the right hand of the victim, place your hand behind the back, support the head, and turn the patient as a one unit, sir. Because at that point, you don't know whether there is a fracture of the cervical spine. So
Yeah.
turning as one unit is very important, sir.
Sure.
That's it, sir. That's it, sir.
Absolutely. You can see my screen. Can you all see my
Yes,
screen?
yes, sir. We can see you.
Everyone, please, what we normally do is, victim is in supine position, raise victim's left hand, which will support his neck on this side, and his other hand here. And then in the whole body you turn, so that the head doesn't fall on the lateral side, because there is a width of the shoulder. So his own hand will support a M when you turn and log roll him completely. That's how we give the recovery position.
Srinivasarao.
Sir, chest compression, PPT patterns.
Yes. Shall I run?
Please, sir.
All right.
Before starting the skill of chest compression, I want to tell some words regarding recently our NMC they gave some guidelines regarding the how to teach a skill as a faculty. So what is a skill? Skill is the ability to perform a task leading to a specified predefined outcome. So many skills are there: cognitive skills and psychomotor skills and communication skills and team skills. Our this chest compression come under the psychomotor skill. In this skill, we have the 4 steps. The Pitons approach is a recent approach which the NMC is recommended us to teach any skill with the Pitons approach. In Pitons approach, we have the 4 things. One is a demonstration, second is a deconstruction, third is a comprehension, fourth is a performance. So what is a demonstration means? The who is teaching the skill, he has to demonstration without telling anything. Then the second step is deconstruction. In the step of deconstruction, he has to divide the steps of the skills. It's number 1, for example, chest compression. First step is you have to identify location of the where you have to keep the hands. Second, how to interlock. Third, how to do the chest compression. And fourth, how to his position, how to do the procedure. Like that, you have to deconstruct the entire procedure, and you have to tell your trainee people. Then third is a comprehension. In comprehension step, the trainee people they will guide you. You are a trainer. They will tell to the trainer to do the steps 1, 2, 3, 4. And fourth is performance. In the step of performance, they themselves they will perform this step, and you have to see that they should do the things perfectly. Like the Pitons approach, in every skill, you have to approach the Pitons approach. Now, the chest compression. So that is first after early recognition identification, what we are doing is early high quality CPR. So we are telling that what is a high quality CPR. So for the high quality CPR, we should do the effective chest compression. For effective chest compression, we have 4 things. What is the 4 things? One is a rescuer position. So where the rescuer should sit or should stand and along the victim. Second, identification of side. Where should he has to compress his chest. And third is the placement of hands. How to placement of your hands. 4 is how to process chest compression. If you follow these 4 guidelines, then only it will cause a effective chest compression. Then only it will lead to the high quality CPR. Otherwise, it won't call as a high quality CPR, because if you follow the 4 things only, then the procedure will be very easy to you, because you don't know how long you have to continue the CPR. So you have to tell all the students, see, these 4 important things are very important. So next, sir. So for effective chest compression, shift the victim on a hard surface. This is very important, because you are compressing the power should reach the to compress the heart and it eject the blood to the upwards. That's why the beneath the hard surface is very important. So between 2 hard surfaces, we can compress the chest very effectively. This is the next slide. So what is your position? Rescue your position. You have to kneel beside the victim. So which may be the side, or the right or left. So either side of the victim, you have to kneel beside the victim. Second thing is a very important thing. Waist of the rescuer should be above the patient. Why the waist up should be above the patient? If your chest is above the victim, your upper part of the body, the weight of your upper part of the body, it will support you to do the compression very effectively. So, for example, if you take the 4 kg stone and you break the glass, and you take the 8 kg stone, you break the glass, which is more effective? So, 8 kg stone, because the weight is more important. The weight of the upper part of the body, that will help you to do the chest compression very effectively. You have to tell all the students the waist should be above the patient. That is very important. Then only the chest compression will be very easy. Sir, next slide, sir. So identification of the lower end of the Giffard process. So how to identify the lower end of Giffard process? You have to tell the students, you come from the midline or from the umbilicus. So it will come the soft, and some point it will come to the hard point. That is a junction. Or you come from the above, the midline, from the sternum. Hard, and soft part. The soft and hard part junction. So like the local language, you have to tell the students so that they can identify the breastbone and identify the Giffard process. So then thereafter identifying Giffard process, and you have to keep the 2 fingers above the Giffard process. You have to tell the victim how to keep the 2 fingers of the Giffard process, and you have to show the heel. What is the heel? They don't know. So for students, you have to show the heel, and you have to tell them how to keep the hand above it, above the 2 fingers. Next slide, sir. So in this picture, you can see he will identify the Giffard process, and he will put 2 fingers above the Giffard process. That is the lower end of the breastbone. Then first he keep the first heel, and he keep the other heel of the hand, and interlock. So interlocking is very must, because the entire unit should be one single. So with interlocking only, we can get the both hands should be one single unit. Otherwise, the both hands should be, they will move aside, and your compression should not reach effectively to the heart. Thank you, sir. Next slide. So this you have to show this figure how to identify the Giffard process. So red dot. So from the above downwards, from abovwards, from the nipple, or from above the from the upper part of the chest. So there is a hard and soft junction point. So if you're teaching in calls for the lay people, then you have to tell the hard and soft part. That is the Giffy sternum. Okay, they can easily identify. You made them to identify their Giffy sternum. Then only they will correctly perform on the victim. Okay, next slide, sir. So in this picture, how the heel, the green part is the heel part. You have to show the students the heel part, son, and then you have to blue color is second hand heel, and you have to make the interlocking the both fingers as a single unit. So that is very important, single unit, and it should be attached chest only. While doing the compression, wherever the point you located, the point should not change. This thing you have to emphasize the students. The point should not change while doing the chest compression. So entire both hands you should have a single unit. Next slide, sir. So this is your position. So first you have to tell your students, so in this diagram, entire the waist of the above the chest, here three joints are there. One is the wrist joint, an elbow joint, and shoulder joint. These three joints should lock. These three joints should lock. The movement should be at the hip joint only. The movement should be at the hip joint should be. The elbow straight, shoulders above the victim, fingers interlocked. Your movement should be at the hip joint, and then only he will do perfectly. Otherwise, if you and you see the rescuer is very nearer to the victim and he located the vigified person. This is your position, and you have to show the students by keeping the mannequin what is the position. Then only they will identify. Next, sir. So here, so compress the chest at least 5 centimeters, not more than 6 centimeters. Here the students, they will ask you, sir, how we know what is the 5 centimeters? Then we will tell the student that if you do the mannequin, in the airway mannequin, if you do the 5 centimeters, the click sound will come. So like that, you will learn what is the 5 centimeters. Second thing is compress the chest at the speed of 120 per minute. So while you are telling all the things, if nobody is asking the question, you ask the questions to the students. Why 120? The normal heart rate is 72, but here we are prescribing the why 120. Then you have to tell the explanation for them. So in our chest compression, only 50 to 60% only blood will eject. For example, if you take the normal heart 72 per minute. For example, it will pump 100 ml to the brain. Okay, so 100 ml to the brain, 72 per minute. Per minute, it will pump to the 7,200 ml. So, but in our effective chest compression, we cannot pump the 100 ml. Hardly we can do 40 to 50%, maximum 60%. So 60% means 60 ml. So if you do the 120 into 60, that is 7,200 ml. Like that, you have to explain them why the 120 for them. Next thing is allow the complete chest recoil between the compression without lifting the hand from the chest. You have to tell them, so you have to 120 per minute. That means for every second, 2 chest compression. For every half second, 1 compression. For 1/4 second, 1 compression on relaxation. This recoiling is very important because we have to tell all the students when the heart is compresses, the blood will pump out. It will relaxes, it will refills. Whenever the refills, then only we will compress, the blood will eject out. So you have to tell all the students chest should be recoil after your compression. So without recoiling, if you do the compression very fast, the empty heart will compress. So what the purpose of the empty heart? So there is no meaning of compressing the empty heart. So that's why you have to give the time to her chest, to her heart to refill the blood, and then only you have to compression. The next thing is do not stop chest compression unnecessarily. So then you have to ask the students why you should not chest compressions. So while starting the chest compressions, what happens from 1, 2, 3, 4, 5, 6, 7, 8, like that you start so whatever the pressure that is maximum pressure that is exerted, that will eject the 60% of the blood from the heart, that will occur after 6th or 7th beat. It won't come from the first beat. So all 4 or 5 beats, they are wasted beats, wasted compressions. So if you stop again, you can add the wasted compressions. So to avoid the unnecessary wasted chest compression, we should not stop the chest compression unnecessarily. These things you have to tell all your students. Then you have to chant loudly. And you have to practice them. You have to chant loudly. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. Like that, you have to chant while teaching the students so that they can also chant while doing. So after 30 again, you have to start. Okay, after 30 again, you have to start the 1, 2, 3, 4, not 31, 32, 33, because it will take time. Sometimes they will miss the count also. So according to scientific things, only 20 only you can count perfectly. After 20, some count will be miss anybody, because we are doing the two things by doing the chest compression, by doing the counting. So we can miss some count. That's why you have for counting, you have to count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. After 30, again you have to start 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. Like that, you have to teach them how to count also. Okay? Then only they will do the things properly. And you have to tell them, if more than one person, you have to interchange every 5 cycles. So for example, calls, you have to do the 30 into 5. So 150 compressions you have to do without any interruptions. Okay, in the BCLS you have to 30. After 30 you have to do the 2 breaths. So you have to tell the students. You have to tell the students importance of the 5 centimeters. You have to tell the students why the 120 centimeters. You have to tell the students why the chest recoil, and you have to tell the reason of the students why do not stop the chest compression unnecessarily, and you have to tell the student counting also. And these things you have to tell, and you have to demonstrate first. You have to demonstrate. The first thing is you have to demonstrate without telling anything. Second thing is deconstruction means first you have to tell them. So I am identifying the Giffard process. Then I am keeping the the 2 fingers here, and I am keeping the heel, and I am keeping another heel. I am interlocking. I am wasting. My position is like that. Then you have to do the chest compression. Then the compression. Then you have to tell the student, tell the steps. Tell the students, sir, what is the number 1 step, number 2 step, number 3 step. Student will tell the steps, then you will do the things. And finally, the student himself he has to do. This is the technique, what we have to teach, the skill, especially for chest compression and airway breathing also. Because you are all the TOTs, so you have to grab the concentration of all the students. Okay, the lecture should not be any monotony. So that should be didactic, and you have to, while teaching, you have to see the eyes of all the students. Okay, then if anybody some question mark is there, then you have to ask the student what is the doubt. So because while coming to the training program, they have to go with 100% clear idea. Okay, then your skill station also, we have to see the student to perform. First you tell them to perform. So he will do the wrong also. First you tell them to perform. After completion of the step, then you have to tell. So like that, you have to keep hands here. Your position is not good. So your hands you are not interlocking, or you are lifting the hand while doing the chest compression, or you are not counting. The counting and chest compression, they are not going parallelly. Counting is going fast. Like that, you have to correct the student there itself. And you have to make the student to do the chest comp perfectly, because the chest compression is very important thing. In calls, we are not giving the breathing. So especially for lay people, you are teaching. December 6th, we are going to the CPR awareness program. We are teaching the calls in chest compression. Like that, all the things you have to ensure in a local language to them, because they are lay people in local language to understand. Communication is very important. Communication with the victim, communication with the help, communication with the students is very important for us. Okay, thank you, sir.
I can stop sharing for some time. Excellent way, Dr. Suriseti, you described. You also gave a very good training to the trainers that how you should be sharing the skills. The two important thing is, when we teach the science of resuscitation, there are two aspects. One is the knowledge sharing, information sharing, and second is the skill. Now, most of us have a very good knowledge and information, but we lack a lot in the correct skills. So that has to be emphasized a lot. And my experience of last 3-4 years teaching people, including the doctors, in compression, two things I have identified. One is they do with a very fast rate. Instead of 120, I see them doing 130, 140. So best way I teach them with everyone has a smartphone, and we already have a smartphone. So with the timer or stopwatch, in 15 seconds, they should finish 30 compressions. That's what when we teach the skills on the skill session, we ask them to do it so that they get a format. And I give them another homework, like checking the carotid pulse. You tap your feet 30 times and watch your mobile, are you able to tap 30 times in 15 seconds or not? So that they should practice later on. So that emphasizes them it so well that middle of the night when you wake them up for cardiac arrest, they will give the correct speed of compression. And then he also expressed very well about the high performance CPR, the steps, 6 steps, like depth, rate, recoil, do not move your hands uninterrupted. All those things are very, very important. We must emphasize. And second thing which I observed is they don't chant. We should emphasize a lot, reinforce them to chant 1, 2, 3, 4. I tell them that when the CPR is going on one room, the other room people should know that there is a CPR going on. So that 1 to 30 chanting will guide them that this is, so they will rescue, they will come and rescue us also, and or you may have more than one people in the rescue. So that's what we have to emphasize. Wonderful.
So, thank you, sir. Previously also we are doing like that, sir. Now the QCPR came, sir.
Yes.
The QCPR, that it gives what is the percentage of your chest compression effectiveness. That we are monitoring with the QCPR, sir.
Your CPRs have this thing, but the which they do without cardiac arrest, without a mannequin. So that to format their mind for 30 taps in 15 seconds. It's an additional which we give to them. Okay, we can go.
Sir.
Do we discuss Coles guidelines? I don't think it's necessary. Here,
no, sir.
We don't talk on Coles guidelines. Only thing we emphasize to the BCLS students is 4 things are not there when we do Coles. Checking pulse is not there, checking respiration is not there, giving breaths is not there, and we don't teach them AED. So AED is not there in the course. Till we in India, in 5-7 years, we get AED at every common places. We'll have to start teaching AED also in Coles. Till that time, we are holding it. So anybody is going to talk on this Coles? I don't think it's necessary. We have been teaching it for yesterday or so.
I think you have to talk on Coles.
Anybody who has been assigned this lecture?
I think you are assigned that. Otherwise,
Chandradika,
Rajesh Devan. Coles is actually, there is nothing difference between Coles and the BCLS. The only difference is actually we will be teaching it by a school children or lay persons. So we are not much bothered about seeing the pulse. If he is unconscious, immediately you can take charge. When he is not responsive, you can go for compression of the chest. That is Coles. And you have to compress the chest till the help comes. These are the main things in Coles. And otherwise, it is almost the same as BCLS. We can go to the next topic, sir.
Have you assigned this lecture to them?
Sir, shall I take Coles?
Assigned to you, sir.
Please go ahead and quickly.
I have a question about the
I will guide you what we talk when we talk about Coles to the paramedics who are for BCLS. That please go ahead quickly, because there's a lot of repetition of scene safety and all, which we need to quickly run down in the BCLS course. So please go ahead, Dr. Chandra.
Radhika, you're talking?
Sir, should I talk on Coles or airway?
Yes, you go over Coles. No, Rajesh Devan, sir, it is written on you. And
it's on me.
Radhika, you don't waste time.
Okay.
Please,
what I will do is I'll talk on Coles, but I'll not show you the presentation. As we have already discussed what things are not there. But when we emphasize this to the common citizens, we do not discuss a lot of science behind that. We just teach the skills and the value of early recognition of cardiac arrest. So early word is very important. Now, how do they ascertain cardiac arrest? There is only one way. Like for us, carotid pulse is the most important sign. But for the common citizen, it is the responsiveness is the most important step. In that, we emphasize the signs of life. So what are the signs of life? We try to observe. Like when you tap vigorously on the shoulder of the victim and say, how are you? Are you okay? You do not know the language of this person sometimes. He may be, because outside he's a stranger, we are in a strange environment. So this is how you talk to the even paramedics. that when you are in that situation, we try to check the responsiveness. And in responsiveness, what we try to check is he trying to verbalize? Is he trying to speak? Is he trying to cough? Is he trying to breathe? Is he trying to move the limbs? Is he trying to turn the head towards you? Is he trying to wink the eyes? All these are the signs of life. And if the signs of life is there is no cardiac arrest. But if none of such signs you observe, assume he has a cardiac arrest. This is what we teach to the common citizens. Am I making it very clear?
Yes, sir.
So
Yes,
this
sir.
Airway and breathing, sir.
what is the way of ascertaining cardiac arrest? Now, a person who is not breathing, not talking, not moving, for a common citizen, he has to assume he has a cardiac arrest. So we save that 10-15 seconds of time of checking even the carotid pulse and respiration. So that is the philosophy we talk to them. Second is, it works best to whom? And we all know when there is a sudden cardiac arrest, if somebody who is active and suddenly collapse, these are the best victims where the course works the best. And it is very much evidence-based because the body has two compartments where there is a lot of oxygen. One is the lung, 5 liters of air has about 14 to 18% oxygen, and particularly the residual volume, functional residual volume. And second is the 5 liters of blood when he suddenly collapsed and beat the last time his heart threw the blood to the circulation, had full oxygenated blood. And even the venous return, only 1 or 2% is consumed. So there is a lot of oxygen buffer within the blood circulation as well as in the lungs. Your aim of initiating immediate compression is to establish the perfusion to the brain. So the aim of course, teaching course algorithm is nothing else but by luck, if this victim survives, he gets the help or he has been taken to the hospital in a living stage, he should survive without neurological damage. So that is what we emphasize for course. Course has only one motive. If he survives, he should survive without neurological damage. And that is what we emphasize to the common citizens and even to the paramedics and also to the doctors. Because we are not going to give breaths to a strange person, unknown person in a strange environment where we have to worry about our own safety. So these few things we need to emphasize. And in the quality of compression, like Dr. Srinivas Rao described, there is no difference in the quality of compression which we do it, or paramedics do it, or what we teach to the common citizens. So those things, 5 to 6 centimeter depth, 120 rate, his own position, his own ergonomics, waist above the chest, his position of the hands on the chest, and his locking and everything, there is no difference in high performance compression. That's what we need to emphasize. And that skill we need to teach. Even if they fail to recognize, even if the person is maybe moving or he has no cardiac arrest, but if he assumes compression is not going to harm the individual, that's what we teach. And second, we talk to them is the 3 things we must have. One is the willingness to help someone who has collapsed in your presence. It may be an unknown person, it may be a non-environment, it may be people around you do not know, but you should have the willingness to make a difference in his life. Second is the courage, because we all are worried. If as a doctor, I am worried in a strange environment, I do something and he doesn't survive, I'm scared if the people are not knowing me. So one is the willingness, second is the courage we have to create and teach them the correct technique. And certify only if they do correct compression for at least a couple of minutes. That's what we emphasize. So this is how we talk about the course to the common citizens. I don't think I need to show the presentation. If you have the
No need, sir. No need, sir. We can go to the compressor, airway.
You can straight away go to airway now.
Airway.
So is there for science, for philosophy, for technique, you can ask me.
Sir, something I want to share, sir.
Yes, please, sir.
Sir, before what we are doing here is before the teaching the calls, we are showing the videos. So sudden collapse of the victims. We are emphasizing that we are not living in a safe environment.
Yes.
For ours, why? What is the importance of calls to learn? Why we should learn the calls? Because we should know we are living in a very dangerous environment. We are not eating a healthy food, and we are very stressful life running around the money. So sudden cardiac arrest, it may happen any person. by showing the faculty, you may get 15 years, 30 years, 25 years, 40 years from the. We are showing all the videos. So, certain caretakers to you also. So why we are learning the course is you have to create a safety environment around you. If you have a sudden cardiac, one person should be there to revive you. That is the first motto we are inserting into the layman people, sir.
Okay.
Then we are telling, after teaching them, we are telling all the members to please teach the calls to all your family members or village people or apartment people. And we are telling that you are all our after teaching course, we are inviting them. You are all our IRCF family members. You are all our IRCF faculty. Then you go to the villages and you have to teach. So IRCF main motto is every person in a house should know the CPR. So you take the pillow, you take the pillow, and you have to tell them the exact compression how to do. That's enough. That like that we are motivating the all the lay people, and we are telling that it's our commitment to save the life. Commitment to save the life. IRCF is so committed that to teach all the entire India to learn the CPR. One thing is your holy hands, you can save the life. That with your commitment, like that we are educating them, sir.
Okay, let the next speaker goes.
Dr. Suhaseti, what is trying to, let us cut short now. We will go to the next lecture. But before that, what he's trying to tell you is you have to create a background. What is the value of learning calls? And the one idea which I little differ is teaching on the pillow, because that doesn't teach the correct technique of compression. So is to teach them on the mannequins only. So make the arrangement in such a way that in the villages you get at least one mannequin to teach them, because pillow is is dangerous to teach. That's what we are. So that part little I differ, but it's very good idea to create the background and tell them.
One is selling mannequins for 500 rupees.
So now we go to the next lecture, sir.
Next lecture. Radhika?
Yes, sir. I am there.
Oh yeah, you are there. So I'll run the presentation.
Yeah. Or we have to. Sir, you share from yourself.
I'll share it.
Okay.
Okay. Can you see that now?
Yes, sir. Make a full screen, sir.
Yeah, I'll do that. Yes, Dr. Radhika, you can go ahead with this presentation.
Hello, good evening. I am Dr. Radhika, Professor HOD of Emergency Medicine at Government General Hospital, Guntur Medical College. And I did my MD Accident Emergency Medicine and MD Anesthesia. I'm a student of Dr. Kameshwar sir in anesthesia. And today our topic of interest is airway and breathing, the topic which I was asked to speak about. Till now we have learned about the core links of BCLS, and also the sequence of BCLS, and also how to do the compression. So out of the two major parts of cardiopulmonary resuscitation, the compression part is the first major part, and the second part is airway and breathing. So next slide, sir. Next slide. Rashish, sir, next slide. So the major component of airway is to maintain a patent airway and also to deliver a breath. So how do we do that? How do we maintain a patent airway and how do we deliver a breath in case of doing a cardiopulmonary resuscitation, CPR? Next slide, sir. There are two techniques of maintaining the patent airway. One is head tilt and chin lift. The other one is jaw thrust. So how do we do the head tilt? Next slide, sir. So you just go on, no, sir. So how do we open the airway? So usually in a straight supine position, the oropharyngopharyngeal axis will be in like this. So in order to open the airway, you have to get the oropharyngopharyngeal axis into a straight line. For that, you need to do head tilt and chin lift. How do you do the head tilt? Place the palm of your hand on the forehead of the patient. As such, you are doing compressions till then. 30 compressions you are giving. So in order to do the ventilation part, so the circulation part of 30 compressions is done. Now the ventilation part of giving 2 breaths, how do you give it? Already you are placed next to the patient. Just place the palm of your hand on the forehead of the patient, and then with your other hand, 2 fingers of your other hand, just palpate the symphysis menti and make a chin lift. So head tilt and chin lift. Then, sir, next slide. So this is how you place the palm of your hand, and then with your other hand, do the head tilt with one hand, and placing your 2 fingers on the symphysis menti, you do the chin lift. By doing that, what you are doing is your oropharyngopharyngeal axis will come into a straight line so that your airway will be open. In case of a cervical fracture, if you are in doubt, like this patient might have lost consciousness or not breathing because of trauma or fall from height, even in a drowning or sudden diving, there is every chance of possibility of having a cervical fracture injury. So in such conditions, never ever do head tilt and chin lift, because that itself will cause disruption of the cervical spine and further worsening of the condition of the patient. Next page. Next slide. So in such condition, what do? You do the jaw thrust. How do you do the jaw thrust? Place your fingers on the angle of the mandible, okay, and just push the mandible forward. In the angle of the mandible, place your fingers and push the jaw forward. If there are 2 persons, one person can as well maintain a manual spine motion restriction so that the cervical spine is not mobilized, even to a minimal effect also. So how do you do that? You place yourself exactly in the opposite direction facing the patient, because for doing the jaw thrust, you are anyway going to the head end side. If 2 persons are there, if 1 person is there, then you have to do it like how you do it. How you do head tilt and chin lift. But when 2 persons are there, when you have to do a manual spine motion restriction, when you can do a manual spine motion restriction, 1 person can go to the head end and do the jaw thrust. The other person can do the spine immobilization by placing the hands exactly under the cervical spine, from the occiput to the cervical spine, the whole of the neck, and stabilizing it by placing the hands exactly on the person. And even the forearm and everything should be stabilized on the person and also on the bed, so that there will be stability of the cervical spine. Next slide, sir. So how do you, so next slide. Yeah. So how do you give the breaths in case of giving breaths? Sir, the slides have been jumbled as such, but I will tell in this in the same scenario. So there are 3 methods of giving breaths: either mouth to mouth, or a barrier device, or mouth to mask, or bag and mask ventilation. There are 3 modalities of giving breath. And if already Dr. Prashanti has given you a scenario of like patient having circulation but no breaths, and patient having no circulation, no breath. So if the patient doesn't have breaths, is not taking breathing, but have a pulse, provide 1 breath every 5 seconds in the absence of breathing, but the patient will be having circulation. That is, pulse is present, but absent breathing. In such condition, provide 1 breath every 5 seconds. In case of cardiac arrest, where there is no breathing, no abnormal breathing, or complete no circulation, in such condition, give 2 breaths. Each breath should be given in 1 second. Totally 2 breaths given in 3 seconds with a pause of 1 second. In between the 2 breaths. So the end point of this is to see for a visible chest rise and a normal tidal volume breath should be given. How do we give it? We will see as we go on. Next slide, sir. Suppose when you are giving these 2 breaths and you couldn't find a visible chest, don't waste your time adjusting and giving breaths. Your 2 breaths time, your 3 seconds are done. The most important part of cardiopulmonary resuscitation is always chest compressions. Try to minimize the interruptions in chest compressions, which is the most critical element of our BCLS in the core links. Next slide, sir. Airway and breathing. As we already told, maintenance of a patent airway and delivering of breath are the 2 components of ventilation part of the compression ventilation ratio and your cardiopulmonary resuscitation. Next slide, sir. How do you give the breaths? Now, till now we have learned how to open the airway and how to make the airway patent by head tilt and chin lift in a normal person, or by doing a jaw thrust in case of a person you anticipated cervical injury. Coming to the breath delivery, there are 3 modalities of giving breath delivery. One is mouth-to-mouth respiration, mouth-to-mouth, and the second one is mouth-to-mask. The third one is bag and mask. Next slide, sir. Mouth-to-mouth respiration. Suppose you don't have even this barrier method also. If it is your own family member, you can as well go and give mouth-to-mouth respiration. But remember one thing, if you don't want to give mouth-to-mouth respirations, or you don't have any barrier methods or any of these face shields to give mouth-to-mouth or to give breaths, please don't stop your CPR. Continue your compressions at a rate of 120 per minute at a depth of around 5 to 6 centimeters, and with a compression ventilation ratio compressions, 30 compressions, and leave out the ventilation part if you don't want to give the ventilation, but continue your CPR 5 cycles, and every 2 minutes you reassess the patient. That should be continued if you don't want to give ventilation. So the major most important component of your cardiopulmonary resuscitation is your compression part. Don't forget that. If you don't want to give ventilations, that's fine. So mouth-to-mouth respiration, place the shield on the mouth, spread it on the mouth, take a good volume, good tidal volume, pinch the nose of the patient, maintain head tilt and chin lift, pinch the mouth of the patient, take a good volume, give 1 breath in 1 second, then lift your mouth from the mouth of the patient or from the barrier. Take a pause of 1 second. In that 1 second, again take the good tidal volume. Again, give 1 more breath in 1 second. So the complete ventilation should finish off in 3 seconds. 1 second each breath. In between the 2 breaths, 1 second for a pause, for you to take a good breath, and other second to give 1 more breath, and immediately start your compressions once the 2 breaths are delivered in this 3 seconds. And remember that when you are looking for, when you are giving the breaths, always watch for the visible chest raise and fall. If you can't see it, please don't waste your time again and again. If you don't waste your time again and again by trying to give the ventilations. In the first breath, if you couldn't see the visible chest raise and fall, try to again readjust while taking that pause itself, readjust the head tilt and chin lift, and also the barrier method in a proper way, or a barrier device that you are using in a proper way, so that you can give the breath, at least the second breath can be delivered in a proper way. Next slide. Next slide. Again, this is a one more methodology of using a face shield. So coming to the mouth to mask, always place the triangle part on the nasal bridge and the wider part on the groove of the mandible, and try to make a easy technique. So with your hand on the palm of your palm of hand is already on the forehead. So with that, your thumb and your index finger try to come the bridge of the nose, the nasal bridge part of the mask, the triangle part of the mask on the upper side, and already your two fingers are already there for chin lift. So you use your thumb and press the thumb on the wider part of the mask so that the mask is fit nicely, engulfing both your nose as well as the mouth. And again, the breath is given in the same way. Only thing is you have to do the mask properly without causing any air leak, and whatever the volume of tidal volume of breath that you are giving, it is delivered properly without any leak and air escaping from the mask. Next slide, sir. Coming to a bag mask ventilation. You know, this bag mask ventilation can't be done when you are doing a single rescuer CPR. This is done only when there are more than one person to do CPR, because to do the bag mask ventilation, you definitely need to go to the head end of the person. So if you are doing that with when you are a single person and you are doing this bag mask ventilation, you lose a lot of time by shifting yourself from adjacent to the torso of the person to the head end of the person. So you are making a lot of interruptions. The main critical concept or critical criteria of CPR is, one is minimize the interruptions. So you can't do that if you are doing bag mask ventilation in single rescuer CPR. So bag mask ventilation is done when only there are two rescuers, okay, more than a single rescuer. Next slide, sir. Next slide, sir. So how do you do that? Again, the easy technique. The easy technique. Always. Next slide, sir. Next slide, sir. So your position and the rescuer. So patient is always positioned. Sir, next slide. Yeah, patient is positioned in the supine position, and the rescuer should be on the head end. And as usual, like how you place the face mask, even the bag mask, the face mask of the bag mask ventilation, the mask of the bag mask, the apex is placed on the bridge of the nose, and the groove is placed, the base is placed on the groove over the chin, that is the mandible. And you compress the mask. If you are a single person, there are only two rescuers, then you have to do both the compression and elevation with single hand, and give the ventilation with your by compressing the reservoir bag. So how do you do the easy technique? By compressing and elevation. Compress the mask with thumb and index finger, forming a C, and then elevate the jaw, the bony part, with the remaining three fingers, forming a E. And while you are placing this E, always remember that the little finger, your little finger is placed at the angle of the mandible, and your middle finger is placed on the symphysis plantae, and your ring finger is placed in between the two, and see that you catch hold of only the bony prominence of the mandible. Because this whole part is, again, airway, the soft tissue part of the airway. If you compress the soft tissue of this area while you are elevating the jaw, then again you are pressing the airway again. So when you are doing this EC technique, especially the E technique, see that you catch hold of only the bony prominence of the mandible. Next slide, sir. So this is how you do the EC technique. The compression and the elevation, the C and the E. Next slide, sir. Again, bag mask ventilation is also done in the same way, like how you do the mouth to mouth or mouth to mask or mouth to barrier mother or mouth to shield. Again, give 1 breath or 1 second, chant 1001, that is 1 second. Release the bag mask, that is release the reservoir bag, chant 1002. Again, second breath, chant 1003, one more breath, release the bag and start the compressions. So you will be maintaining the open airway by head tilt or chin lift or jaw thrust, even when you are placed on the head and side of the patient or the victim while doing bag mask ventilation or while the compressions are happening. If you have the privilege of having more than one person with you and you are having the privilege of doing some other person doing the ventilation, see that the airway is maintained patent throughout the compression part also. Next slide, sir. So breaths, 2 breaths, each breath over 1 second, 1 pause after 1 breath. Mouth to mouth or mouth to mask or bag and mask. These are the methodology of giving breath, and do not interrupt chest compressions unnecessarily. That is the major critical criteria of doing your CPR. End point of giving a breath is visible chest rise and fall. And if you can't see it with the two breaths, please don't waste your time giving breaths continuously until you get a visible chest rise and fall. Even if that is not seen, that is fine. Please continue your compressions. Minimize the interruptions while giving chest compressions. Next slide, sir. Thank you very much. Thank you, Chakarrao sir, for giving me this opportunity. Any doubts? Just one more thing I just want to add. While checking the carotid pulse, sometimes we will have doubt that we are feeling our own capillary pulse sometimes. Every time we were always taught that if you are in doubt that there is no carotid pulse, or you are feeling your own, there is pulse also sometimes, feeling your own capillary pulse while you are palpating. If you have a doubt that there might be a pulse, you think that if you are having a doubt, please think that there is no pulse and do a 2-minute CPR. That is not going to affect the patient, but you not giving pulse thinking that there is no, you not giving compressions thinking that there is a pulse, you are losing time, right? So always whenever when you are checking for the pulse compressions, I just want to add it when Prashanti has finished her lecture itself, but there are so many people who are linked, so I thought I'll add at the end of my lecture. Because a doubtful carotid pulse means that a feeble carotid pulse means that the patient is definitely having a decreased perfusion. So your 2-minute CPR is not, rather your 2-minute CPR is not going to affect him. Rather, it will be beneficial for him if he doesn't have pulse and when you are in doubt.
Thank you, Dr. Radhika. Very well explained everything, the intricacies of training the students about respiration, as well as the very valid point you brought about is the this checking this thing. Any question? Anybody has any comment to make, or we go to the next lecture?
Thank you, sir.
Thank you very much, Radhika. So next is
Sir, it's me. Good evening,
Divya,
sir.
you to, Divya, good evening. You are going to...
Yes, sir.
Now,
Sir,
when...
Mahendra sir, mute lo pettukondi sir, please.
No, she is with us when we conducted our CCLS in Andhra Medical College. She is an emergency medicine physician from this.
Geetam, sir.
Divya, Dr. Divya sir.
Thank you. Thank you.
Divya is going to talk. She is with the Gita Medical College.
Yes sir, yes sir.
Yeah. Okay. When we talk about this lecture in the class, it depends on who is the class group. Like we are talking to anesthesiologists, we usually the initial steps, which are repetition, which were there even in the first lecture, you can skip a little bit giving the overview. You can go a little faster. And today we have already existing instructors. So just say, what does it? difference.
Yes, sir.
Divya, you are on the screen.
Yes, sir.
Crosstalk.
మా రాధిక రాణి మేడం మ్యూట్ చేయండి.
సార్ మ్యూట్ చేసేసాను సార్ నేను ఆల్రెడీ.
Okay, okay.
ఓకే.
Good evening, sir. Good evening, everyone.
సారీ మ్యూట్ చేసేసాను నేను.
Okay, okay, it's over. Please,
Divya,
please start. Divya.
I am in charge and assistant professor, Department of Emergency Medicine from Geetham. So I'm just like Rashish sir said, this is something that's already been discussed. So I'm just going to quickly run through the single and double rescue scenario where there's going to be a minor differences. Basically, we're going to run through the algorithm. Sir, next slide, sir. Yeah. So this is a very well-known algorithm for all of us, I'm sure. So the first step in this, we ensure the safety and then we check for the response. And then once we check for the response, we're going to activate the EMS and ask the person to get an AED. And then if the patient is responsive, we're going to observe him in recovery position, right? Sorry, if he's responsive, we're going to shift to the medical facility. If he's unresponsive, we're going to check for pulse and breathing at the same time. And we're going to do it in less than 10 seconds. More than 5, but not more than 10. And then immediately, if the patient has normal breathing and carotid pulse present, we're going to put the patient in recovery position like we discussed in the previous lectures. And then we're going to wait for the EMS people to come over and take. The only condition where we do not position or the neck is when we consider a C-spine trauma. So when we do not have a breathing, but we do have a carotid pulse, that indicates that that's a respiratory arrest. So we are going to provide rescue breaths for 5 seconds. So we're giving approximately around 10 to 12 breaths a minute, each breath lasting for a second. 2 minutes, reassess the patient again. And this is going to be done till either the patient becomes responsive or the patient is going to get spontaneous respiration. We're going to come and take over. And then the last scenario where the patient do not have a breathing and do not have carotid pulse, that's when we are going to start compressions immediately without any further delay. So next. When we check for the response, sir, next slide, please, sir. Yeah. When you activate the EMS, it's not like a casual call we're going to call and tell. So we have to make sure you give the necessary details, like you have to identify yourself, you have to tell your location, and then you're going to talk about the victim's condition. And if there's a multiple casualty scenario or a mass casualty scenario, you're supposed to tell the number of victims, them to send the appropriate people and appropriate resources, along with the patient's general conditions, like age, gender, right? And then you also have to tell how many people are there to rescue. And once you have given the information, you have to wait and make sure the other person on the phone has understood what you have told. You cannot hang the phone without knowing that the other person has got the entire information. So next slide, sir. So this is when we're gonna, this is how we're gonna check for carotid pulse and scan for breathing simultaneously to avoid any further delay. And this is going to take around 5 seconds and not more than 10 seconds. Even if 10 seconds, if one is not able to feel the carotid pulse, assume that the pulse is not there and start immediately without any further delay. Sir, next slide, please, sir. Yes. So to feel the
Raghavendra Prasad garu mute cheskondi.
This has been already discussed regarding feeling the carotid pulse. You have to locate your thyroid prominence and trachea and use 2 fingers, and between the groove that we have in the neck, and only on one side we'll have to palpate the carotid pulse. We have to palpate for 5 seconds and not more. Simultaneously, if you stand, it would save a lot of time when the patient is in cardiac arrest. So next slide, sir. Yeah. So this is something that we have discussed in the first opening of the lecture. The 3 different conditions where we see when the patient is unresponsive with breathing and pulse, considering breathing and pulse, and the interventions we're going to do. And the patient has both the pulse and the breathing responsive, where we'll have to wait for the EMS people to come and take over. And then with breathing and pulse, where we give rescue breaths, one every 5 seconds, lasting 1 second each breath, 2 minutes. And then when we don't have hand breathing, that's when we're going to start chest compressions. A delay at the ratio of 30 chest compressions is to 2 breaths. This is going to be universal even in case of a single rescuer or a double rescuer when it comes to adult BCLS algorithm. So next slide, please, sir. Yeah. So this is basically 5 cycles of 30:2 compressions that is going to take approximately 2 minutes of time. And that is when we're going to reassess. We cannot reassess or keep checking pulse intermittently in between the 2 minutes. That would unnecessarily waste time. So next slide, please, sir. Yes. So how hard or how deep are the chest compressions are going to be? This is something that all the faculty have already been discussed. So I'm just going to quickly brush through this. This is quality CPR where the compression has to be at least 5 centimeters, but not more than 6 centimeters, so that the filling of the heart is going to be proper and a proper recoiling should be allowed. And the speed has to be 120 times per minute. And the reason for the speed is if we consider this speed and we give 30 compressions over 2 minutes for 5 cycles, that's going to be your 30 into 5 for 2 minutes. That's your compressions. By 2, that's your 75, actually mimicking 75 heart rate per minute. That's the basic concept of giving the number of compressions with a certain speed over a certain time. And we have to allow complete chest recoil, and we have to allow it without taking the hand off. We just have to make sure your hand is always on the patient so that you waste time again hovering over. And do not stop chest compressions unnecessarily. That would reduce the compression fracture. And you have to count loudly to 1 to 30. And if you're practicing, like Rasesh sir said, you can always do the 15-second thing that we usually practice in the skill session, where 15 seconds of timer is kept and you have to practice 30 compressions. Or you can use a metronome of 120 beats per minute metronome, where you can actually easily access on your mobile phone. That will help you to practice the speed of the compressions. And you have to interchange for every 5 cycles if you have to rescue. Not any further, because this is very tiresome if you deliver CPR in an effective way. But if the person who's doing is, you see that the compressions are not effective, you can offer to interchange in between. Time when you offer to interchange. If not, you have to complete 5 cycles of CPR before you interchange. So next slide, please, sir. Yeah. And coming to breath, 2 breaths. Each breath is going to take 1 second, and then you have to pause for a second after first breath, and then you have to deliver a second breath. So for 2 breaths, you're going to lose approximately 3 to 3.5 seconds, right? And then when you have a single rescuer, you usually use devices like mouth to mask or mouth to any barrier device or mouth to mouth device if you're willing to do it. Mouth to a bag mask device is something that is preferred when you have double rescuer, considering the usage would be difficult. If a single rescuer is there, you would lose a lot of time shuffling, and also you cannot provide a proper if you're using a bag mask device if you're alone, right? And do not interrupt chest compression unnecessarily, and that includes even when you're applying an AED. You cannot stop chest compressions when you're applying AED pads. The only 2 times going to stop chest compressions, even in the process of delivering a shock, would be when the AED is analyzing the respiration. That's when you're not going to absolutely touch the patient, but just you're going to hover over the chest wall. You cannot come completely away from the chest wall. And then next time you are not going to give compressions or stop is only when the machine is delivering the shock. And even then you're going to hover and start CPR immediately once the machine prompts to do so. And the end point of any respiration, any breath you deliver, like Radhika ma'am said in the previous lecture, is going to be a proper visible chest rise that is attained when you give a proper breath for 1 second, which delivers a normal tidal volume. So next slide, please, sir. Yeah. So discuss the 2 rescuer scenario. There's certain advantages. Obviously, when the activity is going to be more, that's something very evident. The differences in a 2 rescuer scenario is you can use a bag mask device in a 2 rescuer scenario, and the chest compressions are going to be effective because the person, if it's a single, the fatigue is going to be more and the CPR cannot be given effectively over a period of time. So we're going to discuss that in detail. It's just a short points that we have. So next slide, please, sir. Yeah. So we have two techniques when we use a device. So that's going technique and double hand technique. The single hand technique is nothing but you attain a seal with just one of your hands. That's your C for compression, E for elevation technique. That's only with one of your hands. And then with the other hand, you're going to pump, you're going to give back the device so that you will deliver a breath. That's for single hand technique. Both hand technique is something that you use when the seal is not properly attained, like when the patient has a huge beard or obese patient, when you cannot achieve a proper seal, that's when you can try using this both hand technique. And how do you know you're not achieving a proper seal is if you can feel the air coming out of the mask is one, and the second one is you do not see a visible chest raise. That's the obvious one that you can tell that the breath you're giving is not being efficient. That's when you can use the double hand technique. But this is going to happen like both the bag mask ventilation is something that you can do only when there are two rescuers, because to attain a proper seal, you'll have to come to the head end and hold it. So that's going to lose a lot of time when there's a single person rescuing. Sir, slide please, sir. Yeah. So the advantages obviously would options, considering one person is totally concentrated on giving derivation and the other person is going to take over the compressions, and then better respiration, because obviously bag mask device will deliver better tidal volumes comparing to your other mouth to mask or mouth to barrier, and also it would deliver a higher FiO2 when compared to any device breathing. So it is definitely going to be better respiration, and you and the rescuers can switch the roles every 5 seconds. That way the quality of CPR would be much better, because fatigue can be avoided in a single rescuer. And with two rescuers with lesser fatigue, the resuscitation time is going to be huge and exhaustion would be less. So the productivity and the recovery of the patient would be much high. So that way, two rescuer is much better than the single rescuer resuscitation. Yeah. So the endpoints of any CPR, all the resuscitation procedures is either the patient is going to be unresponsive, or if the patient achieves a normal breathing and a normal pulse, or the EMS will arrive. These are the only 3 points where you have to stop your resuscitation. Until then, the resuscitation carried on. So, thank you, sir.
Thank you, Divya.
Sir, thank you for the opportunity.
The thing is,
very good job.
you have to sit in the middle of the screen. You turn to the middle of the screen, and you have to see it straight to our eyes, not to a side. That is the way of conveying your message. So still you are to the left, and you have to turn your face to the right. Then only you will be. And now you are all right.
Yes. I was not able to see myself on the screen, sir, so I couldn't adjust it. I'm sorry, sir.
You have to adjust, and you should have good lighting on screen. That is the thing. Any questions? There are some questions. We can clear them later, or shall we do it, sir? Rajesh, sir.
Yes. So the points to emphasize is, again, both the lectures is chanting 1001, 1002, 1003 is well rehearsed and practiced, so that you take 1 second for inspiration, 1 second for exhalation, 1 second for next inspiration, on 4th second you are back to compression. Now, strategy for breathing is, when even if you are two rescuer, first breath, second breath, if you fail to have the rise in the chest, you don't delay compression. As she rightly said, compression is the priority. But second time, you should be in your mind that you adjust the airway, raise the chin or do the head tilt chin lift or do something so that you give a better breaths. Now, second cycle also, if you fail to give 2 breaths and there is no rise in chest, do not delay the compression, because compression is always a priority. But the person who is doing a compression can help by giving a 2-band technique and start giving the breath. So that's the advantage of 2% doing the rescue breaths. And that's the only time you leave your hands onto the chest. If you are too rescuer, please do not take away your hands from the chest if you are giving good breaths by somebody else. Only you leave the chest, your hands from the chest when you have finished 5 cycles to check the carotid pulse and respiration. So that is what we need to emphasize, because leaving the hands, as she rightly said, again you may have to locate where you have placed the original position of the hand. And in Indian guidelines, we recommend that you don't waste time in removing the clothes. You the compression as quick as possible, so that sometimes there's a clothes on and you locate the zipisternum and you start the compression. Am I right? Okay, so we go to the next picture now.
An effective chest compression will yield a very good carotid pulse. That is how you can see it in the subject. We'll go to the next topic, sir. AED.
Thank you, sir.
I don't know why I have selected all good speakers today. I should have selected
good speakers. I'm
so that they can improve.
Sir, I am myself learning few points from them.
Yes, of course.
Sir, can I go ahead?
Yeah, yes. This
Yes.
is Dr. Lakshmi Narayana, my colleague in anesthesia in Kakinada. He has been fascinated towards teaching and learning. He has been actually a AHA instructor, but I converted him to IRCF instructor. Now anything is same, and he is a retired anesthesiologist, but he will be attending my calls whenever it is needed. Thank you, Lakshmi.
Thank you, sir, for the nice introduction. And AED, as it says, is automated external defibrillator. That means the shock is automated.
We are not able to see your thumbnail on the.
Sir, I don't want to distract the audience with my picture. Is it all?
No, sir, please switch on the video, sir. Then only they can
okay.
correct you.
Okay, okay.
Yes, thank you, sir.
So, right. So, automated means the machine can analyze and advise you about the shock, whether it is a shockable rhythm or non-shockable rhythm. And it is an external defibrillator. That means there is an internal also, so that you do during bypass and all that, and it's a defibrillator. Next slide, please. Yeah. So this, we have already gone through this. If the victim is normally breathing with a definite carotid pulse, you don't do anything. You just put the patient in the recovery position, and you will be reassessing every 2 minutes till the medical help arrives and you shift the patient to advanced medical facility. And if there is no breathing with a carotid pulse, you will give a rescue breath one every 5 seconds, and you will be reassessing every 2 minutes. That means you will be giving, as already told, about 12 breaths per minute. And if there is no breathing and no carotid pulse, you will be starting the CPR at a rate of 30 chest compressions to 2 breaths. So 5 cycles you will be doing that, and it will take about 2 minutes, and after which you will be checking the pulse. And in the meanwhile, if the AED arrives, you will be shocking the individual as soon as the AED pads are applied and all and ready and all that. Okay. So now, once you have decided that the patient needed CPR, you will be doing these chest compressions, and then you will check the carotid pulse. And then if the pulse is present, you will check if there are respirations. If there are respirations, so you will be putting the patient in the recovery positions. If there is a pulse without any respirations, you will continue with the respirations and all that. If the pulse is absent, you will continue with the CPR, that is 30 chest compressions to 2 breaths. Okay. So this will go on till the defibrillator or AED is made available. Okay. So, and the defibrillator differs from the AED because it cannot analyze on its own. You have to decide depending upon the rhythm, whether it is ventricular fibrillation or ventricular tachycardia. So yes, you will be doing that till the AED is arrived. And please go to the next slide, please. Why early defibrillation? Yeah, good. So as was already told, the probability of successful defibrillation diminishes with time, because time is life here. Okay. So survival from witnessed ventricular fibrillation causing sudden cardiac arrest. So for every minute, there will be 7 to 10% less chance of survival. So 10 minutes, no chance, right? So even in a witnessed VF and CPR done, so even then the chances are a little better, but not 100%. But please remember that the chances of a victim surviving, that is getting reverted from ventricular fibrillation, is 90% if it is the AED shock is given within 1 minute of the arrest. So that is, time is of the essence here, and we should concentrate on delivering the shock as early as possible, if as soon as the AED becomes available. Okay. So now, so the scenario is, please go on with the other slides. Please come to the slide with the pictures. Yes. The next one, please. The next one. Yeah, you may stop here. So you are continuing the chest compressions because you can't find any pulse, you can't find any respirations. So you are doing the CPR, 30 compressions to 2 rescue breaths. Okay. So now the AED is brought in. Then what you do is you don't stop the chest compressions. They will go on, and you will be applying the pads. So it is indicated on the pads where to stick each other 2 pads. One is below the right clavicle, the other is the under the left nipple to the outer side of the chest. That is how you put it in the common nomenclature. Okay. And before you stick the pads, you have to take certain precautions. Like if the individual is very wet, the chest is very wet, so he was just brought in from the water, something like that, then you have to wipe it, all the wetness off the chest before you stick the pads. And also, if there is a lot of hair, so the pads are not going to stick properly. So what you do is, you can't find a razor and a shave and all that. That will you lose a lot of time. So what you do is, you will stick the pads and just take them away forcefully. So that will remove some hair, and you take another set of pads and then stick them in the proper way, in the proper location. So then they will be effective, because unless the contact between the pad and the chest is total, the delivery of the shock is not complete. Okay. So that is another thing. So another thing you have to watch out is, there might be piercings, and there might be subcutaneous what you call pacemaker might be there, or there can be medicated patches. In that case, you have to take out the patch, wipe off, and then stick the pad. If there is a pacemaker, you have to go away from the pacemaker by about 1 or about 2 centimeters, and then stick the pad there. Similarly, piercings, you try to avoid them as much as possible, and then you stick the pads. So now you have the pads are in place, and remember, the CPR is still going on, no interruptions. At this point, you will press the analyze button. Next slide, please. Okay, so it's all the compressions are going on. Next slide, please. Yeah. Now the pads are in place, and you will press the analyze button. As soon as the analyze button is pressed, nobody will be touching the patient, because your ECG is going to influence the machine. So and the machine will analyze the rhythm, and it will indicate by a voice prompt, okay, whether the rhythm is shockable, deliver shock, it will say. Otherwise, it will say non-shockable rhythm, like it is some pulseless electrical activity, or asystole, then you don't shock the patient. So, okay. So then you will only just continue your CPR. So if it says the rhythm is shockable, then immediately you will see that everybody is away from the patient, not touching the patient. Just don't bother say you are clear, I am clear, everybody clear. No, don't waste your time like that. So everybody clear, and you just visually confirm that nobody is touching the patient, and just press the shock button. Okay, and immediately after giving the shock, and don't wait for the response. Just continue with the chest compressions, 30 compressions to 2 breaths, 5 cycles after 2 minutes, and then you check the pulse. Next slide, please. Okay, so that is what I was just told to you. The chest compression is going on, pulse is absent, so the compressions are still going on. Defibrillator is made available. Then you will be attaching the pads. You will analyze the rhythm while not touching the patient, while nobody is touching the patient. The machine says shockable rhythm, and it will deliver the shock automatically. Now, what is the status if it is a defibrillator, not an AED? Conventional defibrillator, biphasic or monophasic. So if it's a nowadays you see biphasic defibrillators everywhere. All the new models are biphasic only. So there you will start with the initial shock. You will recognize a ventricular fibrillation on the screen of the defibrillator. Then you will give the first shock at 120 joules. Okay. So for biphasic, that is enough. But if it's said to be a monophasic, it should be more, maybe say 200. Okay. So then you will, for the next shock, after 2 minutes, you will escalate it. Okay. But immediately after giving the shock, you will resume the CPR, 30 compressions to 2 breaths for 5 cycles again. Next slide, please. So, yes, this is going to be a repetition. You are going to stick the pads, then you are going to, that is while the CPR is still going on, then you will request everybody to take away their hands, then you press the analyze button, then you will, the machine analyzes, advises you on the shock, then you will, after assuring that nobody is touching the patient because they will receive the shock, then you will press the shock button and immediately you will be resuming the CPR. Okay. So, yeah, next slide, please. Expose the chest and attach the pads, already covered. Next, analyzing the rhythm. And then delivering the shock. Okay. Yeah, then you will be resuming the CPR. Next slide, please. Yeah, then you will be resuming the CPR. CPR again at the rate of 30 compressions to 2 breaths. Again, after 2 minutes, check for carotid pulse, pulse absent, do the shock because the pads are very much there in C2. If the pulse is present, don't do no shocking, no CPR. Okay. Then if there is respiration is there, well and good, recovery position. If the respirations are not there, you will be giving the rescue breaths. Okay. Next slide, please. The same thing. Again, you will do compressions. Again, you will check for the pulse. No pulse. Do the AED, let the AED give a shock. Then you will again see escalate. Please note that under shockable, you can see that defibrillation, you will be starting with the 120 joules. That is the first one. Later, you will be escalating to 200 joules. Okay. So, but AED, of course, you don't have that facility. You don't have any control on that. And for pediatrics, you will be using the pediatric paddles, and that will be less powered. Okay. So yes, next slide, please. The same thing. Next slide, please. The same thing. It only emphasizes that you have to continue with the chest compressions and rescue breaths. And if you can't find a pulse, you will be shocking again and again and again. Yeah, till you get a response. And please note, as long as the machine says shockable rhythm, you have to shock it because you might get a response at one time or other. Yeah, see the last slide. Continue the cycles of CPR till the victim becomes responsive. So how will you know the response? Victim will be moving, coughing, or vocalizing. So, and pulse and breathing returns, or victim is shifted to medical facility. I suppose that's it. Thank you.
Thank you very much, Dr. Lakshmanarana.
Thank you, sir.
Okay. There are 92 people. I don't know how many people are there. I will try to take one photograph like this. There is a facility now in June to take the photographs of all the people who have attended. And there is another, next topic is
Choking.
choking. Who is taking choking? Mahesh and Venugopal are not there, I think. Mahesh, Railway Hospital, Visakhapatnam. Anybody will take? Okay.
Rakesh గారు రాలేదు సార్. రాకేష్ గారు రాలేదు.
Rakesh Chandrapudi,
రాలేదు
if
సార్.
they don't keep them as in the faculty, they'll feel bad. If they keep, they think that.
సార్ వల్లి మేడం చెప్తున్నారు సార్ మీరు.
Valli madam, I'm trying to contact. I think she is there. Sir.
I think she is there, sir. In the boat.
Valli madam, are you there? Can you talk to
Good
me?
evening, sir. Good evening, sir. First problem in the join avvadaniki, then I was been observing in the YouTube, then I got it in.
Okay,
Yes, sir.
you.
Good evening, sir.
Thank you.
Yes, sir.
Dr. Valli, I'm going to talk on choking, right?
Yes, sir. Good evening, sir. Very happy to learn again and refresh again. Many things we are learning from the different trainers and experts we can say. Really, they are all experts, sir. A small, minute things.
Everyone has something different point.
Yes, yes, sir.
So I'm also
yes,
learning.
Sir.
Thank
Yes,
you so
sir.
much.
Thank you, sir. Thank you, sir.
Valli is the Deputy Director of Nursing in the AP government.
Yeah.
She is very fascinating in teaching. And I have observed her that she has intention to teach, and she is feeling happy to be associated with IRCF. So now, what topic you want to talk about?
She's going to talk on choking, but sir, I would like to make few comments on the AED for the educators, trainers. Dr. Valli, just hold for a couple of minutes. What I want
Yes, sir. Yes, sir.
When you are talking to the doctors about AED, we discuss at length the regular defibrillator also, because in-house cardiac arrest, when they get it, they have to interpret the rhythm and then decide 120 joules is a shockable rhythm or not. So that interpretation is necessary. When we talk to the paramedics, particularly nurses, they do not have the exposure unless they've worked in ICU. So when we talk to the nursing college, we just talk about AED and use of defibrillator little briefly, because that will be futile to talk to them. Number 2 point is, when we talk about AED, and as Chakra also said that at 2 cycles you got the AED, use the AED, shockable rhythm, shock the rhythm. Now all these machines gives the prompt and they do automatic work, except one thing. Delivering the shock is always manual. So charging is also automatic. You don't have to charge AEDs. All machines, they give the verbal prompts and they work automatically, except the last point of delivering. Because delivering the shock, if it is automatic, somebody is touching the victim, there can be a chance of injury. So delivering the shock is always manual. That's what we need to teach. Second point is, when you deliver the shock, do not waste time. 5 cycles of CPR, even if you had interrupted at 2 cycles. Next is only 5 cycles. At the end of the 5 cycles, what do you do? That you need to teach. And normally, it was mentioned in the slide also, that once you have delivered the shock, you finish 5 cycles. Our 5 cycles are never 2 minutes. I saw 2 faculties making that mistake. It is never 2 minutes. Our 5 cycles are 90 seconds. So we never write or talk 2 minutes, 5 cycles. We talk only 5 cycles. That you must understand. Second point is, when you finish 5 cycles after delivering the shock, you check the shockable rhythm only. You don't check pulse. So you check that the rhythm is still shockable or not. If it is shockable, deliver the shock and again 5 cycles of CPR. But if it is non-shockable at that stage, there are two possibilities. Either it has turned into a non-shockable rhythm or pulse has appeared. So at that time, you need to check the carotid pulse and respiration. So any additional 10 seconds you take to assess the victim. Am I making it very clear? So
Yes,
this
sir.
is
Sir, one more question. But AED is so, so tuned that it assess and reassess every 2 minutes. It doesn't assess like how we do it in 90 seconds.
That's
like
right.
1.5 minutes.
That's right.
The problem with AED assessing is it assess every 2 minutes, it assess by itself. So what are we going to do for the next 30 seconds?
Absolutely right. So in Indian guidelines, we ask them, so once the shock is delivered, to switch off and switch on again.
Yes.
That's why you don't spend 30 seconds. You understand my point? Whole idea of Indian guidelines, the beauty is the compression fraction, which is about 67 to 74% in all international guidelines, which is about 83% in Indian guidelines. That's why our rate is faster, 120, and we waste only 3 seconds for respiration. So,
and one more thing I just want to add, sir. Whenever we are attaching the paddles, we have to look after few things about the watery chest, hairy chest, and any medicinal patches or any ICD placements. And if the paddles are to be used for a pediatric or an infant, where there is no infant paddles or pediatric paddles, see that when you attach the paddles, those two paddles will not touch each other.
You
Place the paddles in such a way that they are apart.
Radhika, Dr. Lakshminarayan already mentioned all these points in his slides,
Okay.
in his lecture.
Sorry, sir, because I was in that travel.
One thing I want to add is chest could be wet. Most of the time, patients are not brought from the swimming pool.
Yeah.
Because they
because
get
of even
Radhika, let me finish first. When they get a cardiac attack or something, they sweat a lot. You know, they are sweating before they go into cardiac arrest. That's why their chest is wet. Not that every time we bring the patient out from the swimming pool. So even if they are out, not in the swimming pool, even if they are in the gym, they are wet. And cardiogenic shock, they sweat a lot because of the cardiac shock. That's why we have to use the wiping out the chest. And every AED, now in the assembly, there are 3 things requirement. One is the lot of tissue, disposable razors to shave the chest, and a strong scissor to cut the clothes, because till that time you are not removed the clothes and you are doing the compression. So for applying pads, you need to cut the clothes, and clothes we teach them that when you cut, do not stop compression. From the sides you cut, so that the area where you want to place the leads are open, and you have to remove the hair also. And he gave the idea of putting this pad 1 and just take it out. That will pull out the hair. So there should be at least 2 set of pads.
2 paddles.
So these are the accessories should be there. 2 pads, strong scissor, disposable razor, and lot of tissues to wipe the chest. These are the part of the accessories we must have with the AED.
Yes.
Thank you, Radhika. You also brought very good point. And we can go to
and at the level of third, when the AED is assessing the analyzing the rhythm, sir, one step you do is stop the CPR while the AED is assessing.
Yeah,
and you do not touch the patient, and at the same time you switch the roles, because till that time you are doing the CPR, you will be exhausted. So the person who brought the AED will go for the circulation part, that is compression part, and the person who is doing compressions will go to the ventilation part.
Perfect.
That's one point I just want to add.
Okay, so we go for choking. Dr. Wali, you are ready, no? I'll just share the choking lecture.
Yes. Yes, sir.
Okay.
Yes, sir. Good evening, sir. Thank you for giving opportunity to refresh ourselves. Yeah. I'll start, sir.
Yeah, please.
Yeah, as such, we have been learning about the CPR, and we have been learning how to save the life. Though it is very simple, it looks choking. Yes, choking is very, very important one that one need to relieve and make them to have it. Why, when choking will occur? Yes, choking is nothing. It occurs when an object, or most importantly, the food, we are all the food lovers, becomes lodged into the trachea and it blocks the airway. When the airflow is blocked by the food or any other objects, it is called as a choking. Yes, choking can be a medical emergency and need an urgent attention. And what are the main symptoms of the choking? Yes, the main symptom of the choking is inability to breathe because it is lodging in the blocking the airway. The person cannot breathe or talk. As it goes in the airway, the person cannot breathe and even they cannot say anything. There may be a accompanying cough. Sometimes severe cough will be there, or sometimes you will see that person will be silently will be showing some bluish discoloration or the cyanosis because the person is not getting the oxygenation and breath is being blocked. It's very, very important emergency. Is it common? Yes. Yes, it's very common. Most of us in our lifetime, one or other time, we all will be experiencing this choking. We don't know how bad that will be the experience. If it is blocking the total airway, it's very, very fatal. More than 10 million cases per year in our country, they will be getting the choking. Yes. How will you diagnose the choking? Yes. This is the universal sign. When you see a person suddenly in front of you or somewhere in the street or somewhere in the group, suddenly the person will be, hands will be clutched to the throat. Something is blocking, something is obstructing. So their hands will be clutched to the throat. That is the universal sign. Then what are the other signs? Yes, if a person does not give you that signal, the person is not giving any signal and looks that had a choking, he is an inability to talk. He is not able to talk. He cannot express what is happening and will have a more and more difficulty in breathing. And as such, the breathing, how it will be? Something is blocking in the airway and air passages. Automatically, the breathing will be noisy breathing. Something is obstructing. The person keeps the hands, both the hands at the neck, and he will be wanted to shout and cannot shout. And noisy breathing will be there. That we call it the term as a stridor. Yes. Sometime when you go in the wards or in the places, you will be seeing the different noisy breathing. This is a very typical difficulty in breathing, that stridor. And the sounds will be, the person will be trying to breathe, and sometimes the person starts very severe coughing with forceful cough. And most of the time the person will be looks very tired and even loses his or her conscious level, becomes unconscious. And as soon as you will look, the oxygen levels are going down, the lips, skin and the nails all will become started bluish discoloration. These are the various signs and symptoms that we may come across when a person is been having a choking, and you will start diagnosing the choking. What you will do once you have been diagnosed? Yes, we need to relieve the choking and we need to manage. First of all, as a stranger, as a person, you are being their rescuer, immediately first you introduce, otherwise the person goes into more and more anxious and becomes more worried. So introduce yourself. I am here. Reassure, not to get worried. Emi kaadu neeku, nothing to be worried. That reassurance makes the heart levels and to come down, and person will be think. Explain the procedure. I'm going to help you. I'm going to do the some procedure. By this, your blocking in the airway will come out. So we start that procedure after explaining. What is that manure that we will call it? It's a Hamlin manure. What it is? It's a very simple, though the word is being used as a Hamlin manure, it is a very simple manure that nothing but it is called it as a abdominal thirst. What is that thirst? Thirst is something that you will be giving with your hand, a forceful blow that you will be doing with your hand. It is been called as a abdominal thirst or Hamlin manure. Someone else that they will be doing. What we have to do? Here, you can see in the figure, it's very clear. The rescuer is at the back, standing at the back of the individual. Behind the person has to stand. Place one foot straightly in front of the another foot, so that, see, when we are rescuing, first of all, we have learned in our CPR, in our calls, safety is the first important thing. Yes. So you have to stay stably with your broad balancing, and wrap your arms around the waist of the individual. See, like the person is been wrapped, his hands around abdomen ke around ga petteskovali. Tilt the person little bit forward slightly, not completely bending, little forward, and make a fist with one hand. See that your hand will be made like a fist, yes, with one hand, and position slightly above the person's umbilicus, or we call it as a navel. So umbilicus ni identify chesi, you have to identify the umbilicus and put your hand, one fist hand over the umbilicus, then take another hand, yes, over this hand, and with the quick and also with upward thrust, yes, you have to give the abdominal thrust, yes, so that how many the blow that blow will make whatever the block that is there in the airway, that will come out. So you have to make a fist with one hand and press with another hand on the abdomen with a quick and upward. When you do it, what will happen? Automatically that force will make the air to blow and to come out of the blockage, and it will be coming out. Yes. When it is been, how many times one can perform? 6 to 10 abdominal thrust. Sometime with 1 or 2 only it will come out. Then you can stop it. If it is not coming out, you can perform 6 to 10 abdominal thrust unless the blockage is been coming out. We can see very clearly here how to locate in the next figures. We can see that. Yes, how to locate the umbilicus. Yes, put your hand and you just navel point. You have to locate the umbilicus. Then the next point, that you are where you are standing. The rescuer is standing in front or at the back? At the back. Yes. Yes. Then you have to make your fist with one closed fist. You have to make it above the umbilicus and then support with another hand. Yes. In the fist the hand that is made fist, the pedicle begins in a hand will be inside, and over that another hand. Then upward and inward thrusts. Yes, the person will be slightly bending. Then you will be giving upward and inward abdominal thrusts. When you are been doing this pressure, when you are been applying this one, automatically the blockage or the whatever the object that is been there, this will be coming out. One important thing that we have to remember is in the sequence of the activities that when you are been performing the this choking in the adult, if you are been there, only one rescuer you are there. First, it is important is to perform the abdominal thrust before calling to your 108 or XYZ or other helping emergency numbers. First, remove the block. Try to remove the block. If you are alone, if there is another person, call for the help and ask that another person to contact the 108 and other emergency toll numbers so that they will come and they will doing the first aid. If the person becomes unconscious, yes, the object is not came out and the abdominal thrust is not helped, then you can go with your whatever the steps that we have learned in the earlier sessions. Yes, either ordinarily you can perform the calls or you can go with the BCLS, whatever you are being required as per the need, as per the things that you will be doing for the person. So abdominal thrust is one important thing is first make the person to understand, I'm so and so, I'll be helping you. Then stand at the back of the person, make the person slightly bend little bit forward. Take one, identify the navel point or the umbilicus. Then with one hand make a fist, with another hand over that you press it for 6 to 10 times unless the object will be coming out. Meanwhile, the other person will be taken. We can see that the choking, most important, the 3 important things, that is inability to talk. These are the signs that you will be observing to diagnose, or the person will be starting coughing. Then universal choking sign. What is the universal choking sign? రెండు చేతులు ఇలా అడ్డంగా పెట్టేసుకొని గొంతులో something is been blocking. That's the universal choking sign will be there. Then slowly you can also see the sound, noisy breathing or the stridor, and discolor, the cyanosis signs will be there. Yes, as what is the response of the choking? Yes, then the response is we expect with a good abdominal thrust, the object will come out. Yes, there is a response, yes or no. If the response is yes, reassure the person, nothing. నీ తిన్న మింగినటువంటి ఫిష్ కానీ లేకుంటే ఫుడ్ కానీ ఏదో వచ్చేసింది. చికెన్ పీసెస్ మోస్ట్ ఇంపార్టెంట్లీ we will be seeing in the restaurants or in the people, in the children when they are playing or anything. వచ్చేసింది, not to get worried. Yes, then you will be calling the 108 and making the person to get the medical help. If it is not coming out, the response is not there, then immediately the other person or you will be calling to the 108, and as per the requirement, the CPR will be performed to that individual. Yes, this is about the choking. Yes, if the object is very big, as it is not able to come up, then automatically, yes, what we have to do? Yes, what we have to do? Yes, the person is going to be becoming unconscious. The cyanosis levels are being not there. As we have learned in our CPR techniques that we start checking the pulse and also giving the things and putting the person in the recovery position and immediately maintaining the airway and sending the person to the quickly for the medical help. Yes, thank you.
Thank you very much.
Thank you, sir. Thank you.
She is actually in the administration for the last so many years, but
Yes,
she has a fascination for teaching. That's how he has even without informing her, we have given her a topic and she could come spontaneously and talk. We are very happy that she is with us, and I think she'll be one of the members of the important members of IRCF, and she'll be delivering. And
thank you very much, sir. I thought choking is one emergency. When you have been asked, I need to make it my learned things for the useful to the our group. Thank you very much, sir. And there is some question in the chart, sir. When there is a big object, when it is not coming, how to maintain the airway? One of the participants has been asking, sir.
You follow the airway guidelines.
Yes, sir. Just now it has been completed. Just we had a section on the airway. Yes, sir. Thank you, sir.
By the time, of course, suppose you may get a cardiac arrest and all, you have to follow the same sequelae like what you do it for COLS or BCLS, and you have to follow. And again, while you are doing the BCLS or CCLS, you try to remove it and restore the airway. That is the only thing. No, when the object is inside, it is difficult to maintain the airway. Sometimes there will be a partial obstruction that may be leading to a partial airway obstruction, and some sort of air will be going up. There we can give a little more oxygen, or we can do a cricothyroidotomy and save the victim.
Yes, sir.
Let me elaborate a little bit about that question. Whenever there is a choking, the obstruction is at the glottic level, right? And the obstruction is because of the large object closely over the vocal cords. Now, obstruction is because of the size of the object as well as laryngospasm. Both things add to the choking. That's why they have the stridor. Okay, you understand that? Now, when somebody collapses, the vocal cord is relaxed completely in hypoxic stage. So when somebody becomes flat on the ground, and if you make him flat on the ground and he collapses, the vocal cord is relaxed. So the foreign body gets dislodged from the vocal cords. It may fall in the pharyngeal area or it may fall in the tracheal area, depending on its size. So both ways it opens the airway. Now, the question here is different. When you see the object in the mouth, you have to swipe it out. So you open the airway so that it from outside also it does not, even if it is not choking, but still it can obstruct the glottic opening or it can again cause choking. So when you see the object, you swipe your finger and bring it out. Or the question is the object is still inside, can the airway be patent? It is difficult. But when it is in the pharyngeal area, you can still ventilate if it is not too large. And usually it is not very large to make the whole mouth full. It is only enough to close the vocal cords opening, completely choking. So that object, if it is that large, you can always swipe it out. Even if it is smaller than that, you can swipe it out. And if it falls within the trachea, you can ventilate. Even if it goes in one bronchus, still you can ventilate the other lung. So if it is beyond vocal cords, it is easy to manage. If it has come out of the vocal cords, it is easy to manage. And this cardiac arrest is sudden, and cause you know the reversible cause. So it's little sleepier. You start in, if it is a cardiac arrest, patient recovers even with the foreign body in the pharynx or trachea. And I have an experience once.
Yes.
So any
Okay,
more
sir.
question? Or we go to the special situation lecture?
Special situation.
Thank you very much, sir, for a very
you,
clear
thank you,
explanation, and thank you.
Thank you, Ali.
Thank you, Chakrao Garu, sir, for giving me opportunity. Thank you very much, sir. We
Thank you,
got it
sir.
right.
Kumari,
Thank you, sir.
raised this point so I could give the explanation.
Yes,
Okay.
sir.
So I have who is this next speaker?
We'll come as next speaker.
Nobody is there, sir. Rashish sir only.
Me?
Okay.
Yes, sir.
Okay. Okay, I'm being taken to surprise, but let me do it.
Yes, sir.
No, actually, this is we thought that we have to recapitulate what our people have learned and how the different CRTCs are doing. But of course, all these people are excellent. But I'm not I'm satisfied, but I wanted to conduct one more session like this with the new speakers, so that everything will be covered from Nandiala, from some other medical college where I have some doubts. Let them talk, and we'll be sitting in. All you people are very, very learned, and you're talking. And after this talk, Professor Susila will talk about the what we have planned for training the nursing students, 20,000 nursing students in Andhra Pradesh. Now you please, sir. Dr. Rashid Dewan is the National Director of Training, and he is a Director of Raghunath Hospital. He mostly is an analyst for ophthalmic surgeries, but he participates in everything. He has a very good fascination towards teaching, and especially the workshops. He is there wherever there is a workshop, whichever type of workshops, he will be there. And we are actually indebted to him for all these services to IRCF. Thank you, sir.
Thank you, sir. Very kind words. It's your vision and your blessings. We all are working endlessly. Is just because it is your desire and your feelings understand the most. Anyway, the last lecture on this session is the CPR in special situations. Now, let me make it very clear. In the life, we have a normal life, right from birth to end. We have a physiological divisions in the life. Like when we are born, we are neonate and infants. It's a separate physiological situation. And second physiological situation comes to the lady in pregnancy. So they are a normal body, normal adult. But in the pregnancy, there is another physiological division, and there are changes happening in the body. So these two physiological situations are slightly different. That's why there is some difference in the CPR also. And you all know, first we start with the baby. Infant and children are not the miniature of an adult. They have not only anatomical difference, but they have a lot of physiological difference. So that part, how CPR differs in this, we will talk. Third physiological division is geriatrics. But for CPR or resuscitation, we consider them like adult only. So we not separately consider. And because these are physiological divisions, we have a separate neonatologist, we have separate pediatricians, and we have separate obstetricians. they have mastered these physiological situations, even if they don't have any other disease. So let us begin first with the child. So the basic principles, whether they are infants or children, are the same, like sin safety, responsiveness, call for the help. All these points are same like an adult and high performance CPR. But the difference we'll try to understand are because of the difference in the anatomy, physiology, and causes of cardiac arrest, which are slightly different in children and infants. As you know, the anatomy and physiology, they are not simply miniature. They have a difference in the sizes, shapes, diameters, and physiological parameters. But for the causes, the most common cause of cardiac arrest is respiratory in children and infants. So adult patient has a cardiac cause as a cardiac arrest, while they have hypoxia as the most common cause as cardiac arrest. So after checking whether the scene is safe, for responsiveness in adult, we tap on the shoulders, while in little grown-up children, we still tap on the shoulders, but infants, we tap on the feet, and we try to check the responsiveness. We check the signs of life in an adult, which are almost similar in children, but in the infants, we see that same thing, but they may cry rather than speaking. And again, in the same, we activate the emergency medical service. It is same when we find a child or an infant non-responsive. So for breathing and pulse assessment, same thing we do follow in 5 to 10 seconds. In a child, we check the carotid or femoral pulse, which are most close to the heart. Like adult, we check the carotid pulse only. But in infant, we check the brachial pulse at the midway between the arm, between the biceps muscles and triceps muscles. There is a groove where we can easily, you can palpate your brachial pulse also there. So we check the brachial pulse. Now for breathing and pulse monitoring, we have to monitor if both are present. If breathing is not there and pulse is present, in adult, we were teaching one respiration at 5 seconds. And we forgot to mention with our own technique, when we are giving one breath at 5 seconds, what we do is 1001, we press the back, and then subsequently 1002, 1003, 1004, 1005, we keep bag inflated. So for 4 seconds, we keep it inflated. And again on the 1001, we give the inspiration. So always inspiration is 1 second and 4 seconds is exhalation. We allow a passive exhalation or there's a silence. But in a child, their respiratory rate is faster. So we provide one breath every 2 or 3 seconds. Infant, it could be 2 seconds. So 1001, 1002, 1001, 1002, like that we do. But it's a little 4, 5, 6 years or 10 years old child. We do 1001, 1002, 1003, 1001, 1002, 1003. That is how we give the rescue breaths when the pulse is present. But if both are absent, if there is no pulse and no respiration, we give the same thing, 30:2. So here we give same 1 second, 1 breath, 1 second exhalation, 1 second, second breath, and 30 compressions with the same rate. But if you have 2 rescuer, like in an adult, the compression is a priority. Here the breathing is also important. That's why we give 15:2. So 15 compressions and 2 breaths if you have 2 rescuers. That's a difference. So first difference was where do you check the pulse? Second difference is the rate at which we give the respiration when pulse is present. And third difference came when there are 2 rescuers, the cycle is 15:2. So try to understand these points. So now about the rate. Rate is same as an adult, 120 per minute, but the depth is different. Usually it is 4 centimeter in infants or 5 centimeter in children. Or roughly you can judge 1/3 of the intraposterior diameter of the chest. So 1/3 of the thing you must compress. That's very easy to judge for people like us. Again, allow complete recoil in between compressions, minimal interruptions, all these things are the same. Now for technique of compression, in a child, it is almost same as adult, but in small child or an infant, we do with only one hand so that our force is less. So try to do compression with one hand. And in infants, you use 2 fingers And here we don't go for 2 centimeters above the ZP sternum. We go in the low. It is very easy to expose child, where it is difficult to expose the adult patient, adult victim. So here you just simply remove the clothes or raise the clothes, whatever the small clothes child is wearing above, and you do on the lower half of the sternum. So usually nipple line falls there. You do with 2 fingers. And if you have 2 rescuers, you do with your thumb. Now, this is what we have to demonstrate to the students when we do in the course. Any question on this? I think there should not be any question. So the key points are breaths are important, as arrest is usually due to respiratory cause, and deliver effective breaths. Second point is keep infant's head in neutral position. Too much extension further obstructs the airway, as hyperextension can create a lot of problems. If you witness the arrest, get AD or defibrillator, go for the help as soon as possible. But if you see a child in arrest who have not witnessed, start CPR first and then call for the help. So that's the fourth difference which came in the child. If the single rescuer, ratio is 30:2. If you have 2 rescuer, ratio is 15:2. So these are the differences in having performing high performance CPR in a pediatric patient or in child. Now we go for a pregnant lady. Pregnant lady, particularly, this applies more to the hospital cardiac arrest, but some principles are useful even for the cardiac arrest outside the hospital also. Like basic principles are same like an adult non-pregnant person, like scene safety, checking for responsiveness is same like it's not a child, it's an adult. So those are same. The difference are due to little bit of physiology. So here there are 2 lives important. So when you call for the help, you don't only in the hospital you activate the code blue, but you also call an obstetrician and a pediatrician, because there are 2 lives important at this stage. Mother and the baby, both are as the risk. Now, normally, we are anesthesiologists, so we know about the supine hypotensive syndrome. We give the anesthesia or spinal anesthesia to an adult for cesarean. Sometimes there's a fall in blood pressure because of the pressure over the aorta and vena cava. That reduces the venous return to the heart. That applies even during cardiac arrest. So either tilting the victim or pushing abdomen is what's recommended. We recommend, rather than tilting by 15-30 degree, pushing the abdomen towards the left side is more useful, because if you tilt the whole body, performing compression is very difficult in an oblique body. So we recommend that you should push the abdomen on the left side. Suppose I am doing a compression from the right side, I'll ask someone to be on the left side and pull the abdomen towards him. Suppose I am doing compression from the left side, the person on the right side will push the abdomen towards me. So ultimately your aim is to push the abdomen and gravid uterus to the left side, so that reduces the pressure over the vena cava and aorta. That will not affect the venous return. Now, this is another difference. Perimortem cesarean delivery. If there is no restoration of spontaneous circulation in first 5 minutes of cardiac arrest, you have to do a cesarean and deliver the baby and keep doing high performance CPR ongoing and try to understand the cause of cardiac arrest in pregnant lady. So there are chances of survival of both the individuals. With high performance CPR, once the baby is delivered, the mother may recover. And if you've done cesarean section in first 5 minutes, the baby also is alive. So this is very important. And in my training programs, I've seen this point is very well missed out by the people. So the key points are, basic principles are same as ordinary adult. Lateral displacement of uterus for 15 to 30 degree is very useful when you have resuscitated the individual and keep him shifted, or must push the abdomen while the CPR is going on. And if there is no ROIC for 5 minutes of cardiac arrest, perform cesarean delivery. That is possible only when the victim is within the hospital, has been admitted in the room or in the labor room or somewhere, or in ICU. You don't shift the victim to the operation theater, perform the cesarean delivery, even if it is in the ward, labor room, emergency department, or in a critical care unit. So any question on this? Any question?
Sir, while doing the surgery, if the pregnant patient she develops a sudden cardiac arrest.
While performing cesarean section.
Yes, sir. Yes, sir. Shall we do?
So you have to deliver the baby and continue CPR. That's the only way you can make the mother survive.
Same on the table itself, we have to continue the.
Yes. If deliver the baby, it takes 2 minutes.
As early as possible, you deliver the baby so that
you have not to worry about hemostasis. Just open the uterus, deliver the baby, clamp the cord. They will not bleed because there is a cardiac arrest. But subsequently, they have to take all precautions when the circulation is re-established. And mother is always a priority, that you must understand.
Sir, somebody will say the prone CPR. Any comment on prone CPR?
Prone CPR is never that effective like in supine CPR. The issue is when you know the pre-arrest condition is going to happen. Best is to turn in to supine and perform CPR. But if you have not witnessed CPR, you suddenly come there and you see there is a cardiac arrest. Check the carotid pulse. If it is not there, you can initiate compression even in the prone, and subsequently when 5 cycles are over, you turn. But this situation is very difficult. Practically, very futile to do prone CPR. Best is to turn.
Hello.
Done the pre-test, which we had sent the link. I'll get the report tomorrow. Yes, I will give it to Chakra sir, and we'll proceed with that.
We need a similar post-test also, sir.
Yeah, I will.
We need a post-test.
The report to you first.
On Google this one only, so that we can assess them. Not that we want to fail them. They are already passed. But
yeah, everybody passed. Everybody is a good teachers. I know that.
No, these teachers, not some people hearing. Next month I will make them to teach. I will not give the topics. I will pick them up randomly and ask them to talk. So everybody should be prepared. So the topics are already in the group. Don't leave the group. The group will be, you will be there in the group and you will be there. And we will be helping the people. And so Sheila is there.
Sir, there is a question. Sarita has asked, Sarita Kumari, are you there? You can raise your hand. You can talk also, I think, if you are there.
Sarita Kumari garu?
Sir, yes.
Answered,
please ask question.
Spontaneous circulation. So cardiac arrest is recovered and generated the stroke volume. ROS is restoration of spontaneous circulation.
Okay, sir. Thank you, sir.
Silas garu maadtara Hyderabad nunchi Silas garu vacharu. I have invited her to see how we are conducting our programs. This is only online.
Responsible
on-site, hands-on will be done. Please express your views, Silas.
Sir, it was very nice attending this, sir. Thank you for inviting. And I have also been part of this since a long time and have been conducting the BCLS, CCLS courses along with Dr. Ashima. And one more thing, this prone CPR, one thing I would like to say about it, sir. In cases where the patient intra-op cases, when the patient is in prone position and surgery is going on and suddenly an arrest happens, at that point of time, we can start off prone CPR and disconnect. Rest of the people can disconnect the connections and then turn the patient and then continue supine CPR and reconnect all the connections. That is one place where this indication of prone CPR, I think, is there.
So whatever you do it at the earliest. You start in the prone and do it immediately to the supine
Yeah,
and do it
as
again.
soon as possible.
Don't lose time.
Yes.
Compression is always a priority. That's why if you have not witnessed, you start with the compression first. Or in OT, when it takes time to turn him into supine, that time you first 5 cycles you must finish.
Yes.
That is not a very effective. Nowhere it has been effective.
It is not the best, sir, but we should not completely be offhand. So we are just starting it while we are disconnecting. That's all.
That's right. There is a question by Vijay Bhaskar about the site for chest compression in pregnant woman. It is same. Lower half of sternum is 2 fingers above. There is no difference. There was the challenge before, and AHS suggested something different. They have also gone back to the same situation, same position. So it is same like an non-pregnant lady or non-pregnant individual place, like 2 fingers above the episternum. Once upon a time, it was different that you go a little higher, but no, it's not so now. Even AHA also changed their guidelines.
Sir, one more thing. Usually the students, they will ask is, while doing the CPR, the rib fracture will occur. What shall you do? So that is a common thing what we are receiving in regular training programs. We are telling that don't bother about the rib fractures. First you save the life, then rib fracture is a minor thing that will automatically treat it. Because we are all TOTs.
Yeah. So the answer should be that fractures have been reported for ages while performing compression. Now, if your technique is correct, your own position, your hand position, and your rate and everything, rhythm, if it is perfect, if your hand is not decentralized, sometimes people lift the hand in between 2 compressions. So then they add a centimeter here or there, and that time there are high chance of fractures. Sometimes the high chance of fractures are there in a very elderly person, but you don't have to bother for rib fractures. Don't keep this in your mind that it can fracture, because compression gets a priority in cardiac. He's a dead man. If you don't do compression with the rib fractures or not, doesn't matter. So rib fractures, and legally you are protected if you get the rib fractures. Rib fractures can always be treated later on. Even bilateral rib can be treated. So that's what we talk to the students. And legal protection.
Sir, Chakra sir, 6th program gurinchi ఒకసారి చెప్పండి సార్. 6th CPR awareness program.
DNB board is there. EBNB board or something like that. They have issued a circular, NBEMS, and the National Board of Examinations of Medical Sciences. They have, I don't know why, they have called for to create awareness on CPR on 6th at 9:30 a.m. I don't know why at 9:30 a.m. And they have addressed all the college, all the places where the national board courses are going on. And I wrote to them, this is like this. We are the Indian Resuscitation Council Federation recognized by this. But they are not very much bothered. Because some of the people are IAS and some of the people are doctors who do not bother about it, because all of them, they are put to the stage by influence or by political atmosphere. So that is being there. Today I have a letter saying, giving one link. You register in that link, and at least all of you register whether you do awareness or not. And what is awareness? Awareness is to tell what to do to your household, to your parents, to your friends, your relatives, to your neighbors, and even your enemies. Because when there is a need for CPR, only those people can do it. I even teach for my people in the club and all those things. Because when we spend time, when Abdul Kalam was arrested, nobody has helped him. And I don't know whether he knows. So you teach everybody. And if you are living in a high-rise building or multi-story building or flats, you have your own AED in the flats, so that no time lapse will be there. And if you are living in a gated community, you should have your own ambulance also, because it is very difficult. Somebody will coming and everybody thinks that we have to go to the hospital. There is no chance of going out to the hospital, and if we goes to the hospital, it is all blood dead. So we have to do something to establish the cerebral circulation. So all these things we have to teach, and let us. I will keep you this this link again in the group. All of you fill the form. At least he says that he will send some videos. He will say some what is that? Some digital certificate and all those things. I don't know. Maybe they may be sending digital certificates. They will be spending some crores of rupees. No problem for us. So let us participate in that. Wherever, whoever does, even AHA comes and do it, we'll do it. We'll participate in that if they allow us. Because it is only to save our countrymen. That is the only important thing. Why I am conducting this program especially because I wanted to refresh everybody. And next month also I wanted to conduct one more thing and keep calling the people from different places. Of course, I have only 100 viewers connection. If it is 100 viewers connection, I am paying about 1,700 and odd per month. If it is more than 100, I have to pay about 9,000 rupees per month. So I'll keep this 100 only. And if 100 is for anybody to get trained, and we'll do a series of reviews, and we will try to assess what we are doing, whether we are delivering our content correctly or not, and let us not give any false certificates or certificates to those people who are not trained. Whatever you take money or not take money, not bother issue. We are just charging only 550 rupees for each certificate of the BCLS and 1,000 rupees for the CCLS. And for the entire course, actually, we are going to do in the next week or so. It was approved. We have to train about 20,000 nursing students. Sushila is there? She might have left. Okay. So if for this 29, we are charging only 1,000 rupees. With 1,000 rupees, we are asking them to come at 1 o'clock after taking their lunch, and they will be trained both lectures and hands-on till 6 o'clock or 6:30. And in the middle, they will be served some snacks and tea, and that is enough. And we will be paying 2,000 rupees for each instructor, and only 4 instructors we wanted to take because we wanted to cut down the cost. And there will be some other cost because the clerical people and all those people, they will be unhappy when you are doing some program and they will not cooperate. You give something to them and all those things. Even at the end of this, if you collect 1,000 rupees for 40 people, you take 40 people, not 35, and we will be saving about 7,000 rupees as per my calculation. With that 7,000 rupees, you keep it there. You can replace your mannequins. You can do something else, and you can make a. మీరు జాయిన్ అవుతారా? జాయిన్ అవుతారు అంటే మీరే ఒక్క మాట మాట్లాడితే నర్సింగ్ స్టూడెంట్స్ ప్రోగ్రామ్ గురించి సరిపడు. మేకప్ వేసుకోవాలా?
Sir, sure.
Okay. అలాగే. Okay. Please join. She wanted to join without video. Probably
Sir,
she needs to
shall I
have-
tell, sir, two things regarding the December 6th program, sir. మనం ఆల్రెడీ ఆల్ సిఆర్టీసీ లో మీరు సార్ వీడియో ఒకటి పోస్ట్ చేస్తున్నారండి కాల్స్ గురించి. చాలా బాగుంది వీడియో. సేమ్ మన కాల్స్ పవర్ పాయింట్ మాత్రం చెప్పండి. అక్కడ డిఎంఏ గైడ్ లైన్స్ నర్సింగ్ స్టూడెంట్స్ వాళ్ళకి కూడా సిపిఆర్ చేయమని చెప్పారు సార్. వాళ్ళకు కూడా ఏం చెప్తున్నామంటే ది కాల్స్ ప్రోగ్రామ్ పవర్ పాయింట్ ఏదైతే ఉందో అది ఎక్స్ప్లెయిన్ చేయండి, మ్యానికిన్స్ పెట్టండి, అండ్ అట్ ద సేమ్ టైం లాస్ట్ లో ఆ వీడియో ఒకటి ప్లే చేయండి. మీకు వీడియో రాకపోయినట్లయితే ప్లీజ్ కాంటాక్ట్ మీ, మళ్ళీ రీసెంట్.
Everything is correct. In Andhra Pradesh, we have everything. All the medical colleges are equipped with everything. But what about the other states?
Yes, sir.
Where are the mannequins for them?
అదే సార్ మన ప్రోగ్రామ్ వరకు ఇది సార్. మనం December 6th మనం ప్లాన్ చేస్తున్నాము, అందరితో కోఆర్డినేట్ చేస్తున్నాం సార్. అన్ని సిఆర్టీ సెంటర్స్ ప్లీజ్ కోఆపరేట్ చేయండి. అండ్ వన్స్ అగైన్ థ్యాంక్ యూ ఆల్ సిఆర్టీ సెంటర్ ఫర్ టేకింగ్ కమిట్మెంట్ ట్రైనింగ్ ప్రోగ్రామ్ గురించి. ఎస్పెషల్లీ వల్లి మేడం గారు మీరందరూ కూడా చాలా కోఆపరేట్ చేశారండి. సేమ్ ఇదే నర్సింగ్ ప్రోగ్రామ్ గురించి సుశీల మేడం గారికి మేము సిఆర్టీస్ లిస్ట్ పంపించున్నాం సార్. ఇప్పుడు మేడము అదే సార్ మేడం గారికి లిస్ట్ పంపించున్నాము. మేడం గారు మనకి ఏ కాలేజీలకి ఏ నర్సింగ్ కాలేజీలు అలాట్ చేస్తారని మనకి ఇన్ఫర్మేషన్ పంపిస్తారు సార్. ఆ ఇన్ఫర్మేషన్ బట్టి మనము బుక్స్ ముందు కలెక్ట్ చేసుకొని తర్వాత వాళ్ళు స్టార్ట్ ఒక డేట్ పెట్టుకొని మనం స్టార్ట్ చేద్దాం సార్.
మీరు మాట్లాడుకోండి. నేను యాక్చువల్గా రేపు పొద్దున్న 6 గంటలు బయలుదేరి విజయవాడ వెళ్ళి ఐ హావ్ టు మీట్ ది కమిషనర్ ఆఫ్ ఫ్యామిలీ వెల్ఫేర్. బట్ బికాస్
దయచేసి అన్మ్యూట్ చేయండి ప్లీజ్. ఎవరో మధ్యలో సార్ మాట్లాడుతున్నారండి.
మాట్లాడబడుతుంది. సో మనం చేద్దాం, ఏమైనా
సార్
మనం సర్దుకోవచ్చు, ఏం పర్వాలేదు. అండ్ యాక్చువల్లీ ఐ వాంటెడ్ టు అరేంజ్ అదే స్విగ్గీ వాడికి చెప్పి మీకు అందరికి డిన్నర్ అరేంజ్ చేద్దాం అనుకున్నాను ఈ లెక్చర్ లో. అంటే ప్రతి ఊరు నుంచి ఎవరో ఎక్కడెక్కడ ఉంటారు
సార్. అంతా అయిపోయిన తర్వాత వీళ్ళు సార్
డబ్బులు సంపాదించడం కాదు, ఖర్చు పెట్టడం కూడా నేర్చుకోవాలి
సార్. మనకి అంతా సక్సెస్ఫుల్ గా లాస్ట్ టైం ఎమ్మెల్యేస్పీలకి ఎలా కోఆపరేట్ చేశారు అలాగా మనం అంతా చేసుకొని ఈసారి కూడా 20,000 నర్సెస్ వస్తారు సార్ అరౌండ్. వాళ్ళందరికి కూడా మనం సక్సెస్ఫుల్ గా ఈ ప్రోగ్రామ్ మనం కండక్ట్ చేసామంటే దట్ ఇస్ క్రెడిట్ గోస్ టు ద IRCF సార్. అట్ ఎనీ డౌట్ అట్ ఎనీ పాయింట్
నేను ఉప్పాడు పట్టు చీరలు ప్రయోగం చేస్తాను. బాగా చేయండి ప్రోగ్రామ్. ఎక్కడ చెప్పండి డబ్బులు అని అనుకోవచ్చు. మీరు వస్తాను, డబ్బులు మనం ఖర్చు పెట్టకుండా ఉంటే డబ్బులు మిగులుతాయి. దాంతో
డబ్బులు ఖర్చు పెట్టండి సార్.
అన్ని సిఆర్టీ సెంటర్స్ సార్ అందరికి రిక్వెస్ట్ చేస్తున్నాను సార్.
ఇంకా ఇంటర్నేషనల్ లైసెన్స్ కమిటీ మీటింగ్ ఇన్ October, but they have not given it to us. Almost they told that they are giving, but they have not given it to us. There is I have saved some money.
అన్ని క్రిస్మస్ ట్రీ ఫోటోలు తీసుకున్నాం కదా ముందు మనం చెప్పుకోవాలి. పిల్లలు తీసారు చూడు అదే ఫోటోనే.
సో మేడం అన్ని సిఆర్టీ సెంటర్స్ ఎనీ డౌట్ రిగార్డింగ్ ద నర్సింగ్ ప్రోగ్రామ్ ప్లీజ్ కాంటాక్ట్ చేసుకోండి, కోఆర్డినేట్ చేసుకున్నాము.
Minister of Nursing AP, she will talk.
Sushila madam, please madam.
Sir, good evening sir, all of you. Sir, thank you Chakrao sir for organizing such a great refresher course for TOTs, and actually I am very glad to have this program sir. Actually today I have received some of the CRTC centers list from Sursetti garu, so I am also waiting for the account numbers and all those things. I will keep a file and I will put in front of the DME for the approval sir. Today also I met DME sir, and he asked me about the process of this progress of this program, and I told the same thing. Soon after getting those account list, we will start the processing of the file. Once it is approved from the DME, we can go further steps sir. Actually so because టోటల్ ఇండియాలో మనము ఆంధ్రప్రదేశ్ ఒక్కటే మనము స్టేట్ నర్సింగ్ కౌన్సిల్ వీఆర్ start initiated this program for all the nursing students. So if we do in a successful way, other councils also will adopt the IRCF guidelines, and our state of Andhra Pradesh will be a role model for the resuscitation classes for the under the IRCF, sir. So previously I also met Rashish Dhawan sir and Chakkar Rao sir at ISACON conference at New Delhi. So we are very happy to coordinate and collaborate with IRCF, and the same thing we are expecting in the future days also. And we are very much interested to implement these IRCF guidelines all over the state councils. So once we are started, it is very if it becomes successful, others also will. Yes, sir. Other councils, Goa Nursing Council also asking, and we will talk with them also, so that they can initiate action from the councils.
Cheddam, madam.
So our state will be a role model for this program initiated by Andhra Pradesh.
Sure, madam.
తెలంగాణలో ఎంటర్ అవ్వాలా? శైలజ్ గారు ఉన్నారు తెలంగాణలో ఎంటర్ అయ్యి నేను వస్తాను 10వ తారీఖున ఏదో ప్రోగ్రామ్ ఉంది, మీరు వస్తారా అని అడిగారు. దానికి వస్తానులే నేను అన్నాను. ఈ లోపల విమానాలన్నీ మునిగిపోయన్నా ఎలా పని చేస్తాయో.
ఇప్పుడు వద్దులేండి సార్, 4 రోజులు మాట్లాడుకుందాం.
మేడం సుశీల మేడం, నాకు అకౌంట్స్ ఆల్రెడీ 80% వచ్చేసినాయి మేడం. ఇంకొక 20% అకౌంట్స్ రావాలి మేడం. పర్సనల్ గా నేను కలెక్ట్ చేస్తున్నాను. అవి రాగానే నేను మీకు ఫార్వర్డ్ చేస్తాను మేడం. నేను మిమ్మల్ని కోఆర్డినేట్ చేస్తూ ఉంటాను మేడం. మనం అంతా లిస్ట్ అయిపోయిన తర్వాత మనం ఎప్పుడు స్టార్ట్ చేయాలనేది మన చక్రరావు గారు సార్ తో మాట్లాడి డిస్కస్ చేసుకుని మనము ప్రోగ్రామ్ స్టార్ట్ చేద్దాం మేడం. వన్స్ అయిపోయిన తర్వాత
inaugural center one day we will conduct starting the program. We will conduct with the Chakkar Rao sir in any CRTC center, sir. So that
okay madam, sure madam. కపుల్ ఆఫ్ డేస్ ఇవ్వండి మేడం, నేను అకౌంట్స్ కలెక్ట్ చేస్తాను. అది ఆల్మోస్ట్ అలా అయిపోయింది. ఒక 4-5 సెంటర్స్ రావాలి. అది రాగానే మీకు హ్యాండ్ ఓవర్ చేస్తాను మేడం.
కమ్యూనికేషన్ వింగ్ లో డైరెక్టర్ గా పెడదాం అనుకుంటున్నా. అంటే షీ విల్ బి కమ్యూనికేటింగ్ అండ్ preparing the newsletters and all those things. She has one computer savvy people. వాళ్ళకి మనం పే చేద్దాం. ఏది జరిగినా ఆవిడ అండర్లో జరుగుతుంది అనమాట. షీ ఇన్ఛార్జ్ ఆఫ్ ఎవ్రీథింగ్. అలా అంటే అందరూ పంచుకుంటే we can share the work, and all of you I name you as director. Whatever director you are, so for a namesake or anything, and I definitely give the utmost value for all of you people, because whatever we are doing out of the box or out of our turn, and we are working heavily. Because for me, I'm not bothered because I'm retired, and whatever I had to do, I have done. My both daughters are married and everything. I have no commitments. But for you, you are in a growing stage. You have to earn a lot, and you have to support your family members and all those things. So that.
సార్ థ్యాంక్ యూ ఆల్ సార్. మనం క్లోజ్ చేద్దాం సార్. 10:30 అయిపోయింది, లేట్ అయిపోయింది ఇప్పటికే చాలా. అండ్ థ్యాంక్ యూ ఆల్ సిఆర్టీస్ కోఆర్డినేటర్స్, ఎస్పెషల్లీ ఐఎస్ఎఫ్ చైర్మన్ చక్రరావు గారు అండ్ వల్లి మేడం అండ్ రషీద్ దివాన్ సార్ and Sushila madam and past president ISAP Prashanti madam for making the success of this program. Sir అందరు తెరవాళ్లే సార్. సో అందరు కూడా దయచేసి రేపు December 6 ప్రోగ్రామ్ లో యాక్టివ్ గా పార్టిసిపేట్ చేయండి. మీకు ఎటువంటి హెల్ప్ కావాలన్నా కానీ దయచేసి నన్ను కాంటాక్ట్ చేయండి. మీకు అన్ని పవర్ పాయింట్స్ కానీ వీడియోస్ కానీ పంపిస్తాము. అదే సార్, చేద్దాం సార్, ప్లానింగ్ చేస్తాం సార్.
గవర్నమెంట్ కి ఎక్కువ ఫిగర్లు చూపించడం కావాలా. అలాగే
లేదు సార్, అందరం ప్లాన్ చేస్తున్నాం సార్. ఇప్పుడు తిరుపతిలో 1000 మందికి ప్లాన్ చేస్తున్నాం సార్. అట్లా ప్రతి కాలేజీలో ఆడిటోరియం తీసుకోండి, ఆడిటోరియం ప్లాన్ చేయండి. December 6th ప్రోగ్రామ్ అందరూ సక్సెస్ చేయండి. సో వన్స్ అగైన్ మన IRCF ని సక్సెస్ఫుల్ గా
1000 మంది 1500 మంది అలా వేయద్దు. మీరు అంకె ఎత్తే 900 326 మందికి చేసేవాళ్ళు. అలాగే 1500 మంది ఏదో 1500 300 అది టీచ్ చేశారు. నేను అడిషనల్ డైరెక్టర్ ఉన్నప్పుడు యువర్ ఫిగర్ షుడ్ బి ఆడ్ ఫిగర్. అది
ఓకే సార్, థ్యాంక్ యూ ఆల్ సార్. ఇప్పుడు 10th అయిపోయింది. థ్యాంక్ యూ ఆల్ సార్, థ్యాంక్ యూ ఆల్ ఫర్ పార్టిసిపేటింగ్ సార్. థ్యాంక్ యూ సార్. With your permission, we are leaving, sir. Thank you, sir.
Good night, sir.
Thank you.
Thank you, sir. Thank you all.
Good night.
Thank you. Good night all.
Good night, Chakra sir.
ఎప్పుడు మీ
Good night, sir. Sister.
Thank you very much.
రాధిక
Sir, ఏంటి sir?
ఎప్పుడు when do you inaugurate your hospital?
We are going to be
Sir,
together.
ఇంకొక 20 days పడుతుంది సార్.
Good. Thank you, sir.
లాస్ట్ వీక్ లో ఉంది.